All right, so I think it's about 5 minutes till 8, just to get, I think people are slowly trickling in just to get things started with intro, so we're on time. Um, I guess welcome everybody virtually to the state of Wisconsin. And we are very lucky that in the state of Wisconsin, we have like large systems like UW Health, Freighter, and Theta Care that comprehensively provide cancer care to the entire state of Wisconsin. And our goal when we started creating these educational symposium was to really educate our practitioners statewide, trainees on new ideas, things that people who are leading the field of brain tumors are doing, and bring those ideas and share it with people here in Wisconsin, so we can provide really cutting edge care for our patients here. Uh, Dr. Bovi and I, we've been doing this traditionally, but this year we are fortunate to expand our committee, and we included 3 outstanding physicians to our committee. Dr. Max Krukov, he's a neurosurgeon at MCW who specializes in brain tumor care. And then we have Brett Morris. He is our very newly minted radiation oncologist at University of Wisconsin. We're very lucky to have him, and he's an exceptional physician. And then Dr. Harsha Pula, who works with Dr. Bovi at Theta Care and is a medical oncologist. So we're really fortunate to have all these exceptional physicians join our committee and to provide like guidance to the meeting and the committee. So with that, I'll let Dr. Bovi start.
That's great. Thank you so much, Dr. Day. As many of the people who are in attendance are fully aware of, there's a significant burden of brain metastases that our patients with cancer face. Brain metastases are projected to be the most prevalent malignant intracranial tumor this year. A more alarming statistic actually is the increasing prevalence of brain metastases. Despite the emergence of targeted and immunotherapies that have successfully eliminated cancer in other parts of the body, the central nervous system unfortunately continues to serve as a sanctuary site for metastatic disease. We are really honored to virtually host this esteemed expert panel this morning, and we eagerly anticipate their insights into the advancements being made in diagnosing and treating central nervous system metastases. We're really excited about this group. They're going to provide an amazing amount of knowledge, or impart an amazing amount of knowledge on us this morning. And it's my great pleasure to start with the introduction of Dr. Jeff Wafel, who's a board-certified neuropsychologist, professor with tenure, and neuropsychology section chief in the Department of Neuro-Oncology at MD Anderson Cancer Center. Dr. Wafel has really become a close friend and colleague with our concurrent work in defining risk factors for cognitive decline in patients receiving therapies for brain metastases. He's an instrumental principal investigator on most all NRG oncology trials, defining the standard of care for brain metastases. We're very excited to have him join us today to kick off our meeting with a talk entitled The Neuropsychologic Outcomes in Patients with Brain Metastases. Jeff, a sincere virtual welcome to the state of Wisconsin, and thank you so much for sharing your expertise with us this morning.
Well, thank you, Dr. Bovi, Dr. Day, Dr. Krukov, Morris, and Pula for inviting me to be a part of the program, and for inviting me to the fall in Wisconsin. It's lovely up there. I love the trees, look great. I will share my screen here. And I'm going to try to switch the screen. This worked better earlier. All right, one more time.
We could see your screen. What are you trying to do?
Oh, I'm sorry. I need to turn it to this mode.
Oh, there you go.
Yeah.
Then up at the top. Yep, there you go.
epic fail, I would say, on screen share. I've doubled my screens, and I'm now trying to undouble them.
That's all right. You're good.
Well, let's see if this will do it. Is that working?
Perfect.
Okay.
Fantastic.
Excellent. Well, again, thank you very much for inviting me to participate with you all today. These are my disclosures. I think it's probably worth starting to just talk about the fact that our brain metastasis patients often first start as cancer patients. And if we just remind ourselves about the epidemiology of cancer and the most frequent sites of cancer and how they vary across both men and women. And we see that the distribution across the world is fairly similar for women, breast cancer being the most common cancer in women kind of globally, but there's some differences for males where the most frequent cancer in European countries tends to be lung cancer. We also have seen over the years the estimated number of cancer survivors in the United States, but I think also worldwide, just trending upward. And this has really allowed us to focus some more attention on survivorship. In 2020, the worldwide incidence of cancer was greater than 19 million. And by 2040, the number of cancer survivors in the US alone is estimated to be 26 million. And when we consider that up to 30% of these cancer patients will at some point in time manifest a brain metastasis, we recognize the scope of this problem. Similarly, by 2040, it's estimated there will be 7 to 13 million survivors with treatment-related cognitive impairment in the USA alone. And this is derived from not just brain metastasis-directed therapies, but many of the therapies that our cancer patients in general experience. And that's really where I think we should start in terms of this trajectory of the cancer experience for patients who go on to develop brain metastases. And this is a relatively simplified clinical scenario where an individual gets diagnosed with cancer, they may require a surgical intervention, and then for their non-CNS cancers, usually non-CNS directed therapies such as chemotherapy, immunotherapy, hormonal therapies, and radiation therapy. And at some point in time, as we said, a relatively large proportion of these patients go on to develop a brain metastasis and then require CNS directed therapy. But even at the time that you are diagnosed with non-CNS disease and receive non-CNS directed therapy, there are risks for cognitive impairment that come from the tumor as well as the treatment. And then the more obvious time that we think about there being risk for cognitive impairment are when we have a disease in the brain and a tumor or a treatment directed to the brain as well. So let's start here, though, for this story. Very recently, Mayo and colleagues out of Toronto reviewed patient reports within the medical record and curated this for evidence of reports of cognitive concerns. And they found very high rates of self-reported cognitive concerns across a wide range of cancer types, with the frequency of those concerns being reported on the order of 60 to 80% of patients. When they did multivariable models looking for risk factors for reporting cognitive concerns, the presence of CNS disease, female gender, anxiety, depression, fatigue, shortness of breath, presence of metastatic disease, and having previously received chemotherapy were all statistically significant in that model. This concept of chemobrain has also been studied in cancer patients using formal neuropsychological evaluations. And in the early 2000s, we demonstrated that women with breast cancer who received adjuvant chemotherapy often developed cognitive impairments in the absence of any brain disease. So this was a neurotoxicity of treatment that happened shortly after treatment and was also seen in later periods of time in follow-up. Similar findings have been reported in ovarian cancer survivors, colorectal carcinoma, testicular cancer, prostate cancer, in which a specific genetic risk factor also has been identified that seems to increase the likelihood of developing cognitive dysfunction when treated with androgen deprivation therapy, or if you're a carrier of this particular SNP. And of course, we've heard of the neurotoxicities associated with immunotherapies and CAR T-cell therapies. A systematic review and meta-analysis of this kind of broad literature demonstrated that the prevalence of patient-reported cognitive concerns, so self-reported cognitive problems, was occurring in 40 to 50% of patients, or even greater in some series, and that there seemed to be some evidence of some increased reporting of problems over time, and certainly no decrease in reporting of those cognitive concerns over time. This contrasts with the studies that used formal neuropsychological testing to evaluate cognitive function, in which the prevalence has been about a third of patients demonstrating treatment-related cognitive decline. That often does persist beyond the treatment period, but there seems to be a decrease cognitive impairment over time, suggesting recovery over time. And this discordance or discrepancy between self-reported cognitive concerns and objectively tested cognitive function is not new. It's not unique to oncology either. And we have proposed some model to account for some of this that is supported by a lot of literature, in which cancer and cancer therapy can cause both objective cognitive impairments, but also be associated with subjective cognitive concerns. One of the differences is that the lack of relationship between subjective and objective cognitive measures often stems from the fact that the subjective cognitive concerns are very highly related to other symptoms like fatigue, mood disturbance, distress, and sleep disturbance, whereas those factors tend to have very little impact on objective cognitive functioning. So as we move toward thinking about patients who go on to develop brain metastases and require CNS-directed therapy, what we know is that the incidence of this, as stated before, is quite large, up to 30% of cancer patients. Primarily lung, breast, and melanoma patients go on to harbor a brain metastasis. There's estimated to be over 170,000 new cases in the US each year. The incidence of this varies by primary histology, with lung accounting for the most, but also breast, melanoma, renal, and colorectal contributing to the cases of brain metastasis. The clinical manifestations at the time of diagnosis for an individual with a brain metastasis include headache in 40 to 50% of patients, focal neurologic signs in 20 to 40% of patients, seizure in 10 to 20%, and less commonly a stroke in 5 to 10% of patients. But there's also a very high prevalence rate of cognitive dysfunction and psychological distress in these patients. Fortunately, we've seen improvements in our ability to prognosticate survival time, as well as to improve survival time with therapeutics that are emerging currently. And this really has focused a lot of attention on not only increasing survival time, which of course is an oncologic gold standard, but also to improving survivorship and making sure that the therapies that we're utilizing to get patients across that finish line are coming with the least amount of toxicity possible. I think it's also appropriate for us to really bring up this concept of early supportive care. Jennifer Temmel and her group demonstrated that early supportive care was improving survivorship as well as possibly survival time, finding improvements in overall survival time in her study, as well as improvements in quality of life and reductions in symptoms of distress, including depression and anxiety. These findings have been recapitulated in other individual series in which survival time as well as quality of life seem to be improved in the presence of early palliative care or early supportive care. So I think we're all encouraged to take this to heart and to try to line our patients up with as many supportive care services as possible, as early as possible. Anna Berghoff and her colleagues at the Medical University of Vienna went to their medical record chart and found over 1,600 non-small cell lung cancer brain metastasis patients, and found that about 75% of them presented with neurological symptoms, the most common of which were focal neurologic deficits. Then they found evidence of increased ICP symptoms, neuropsychological symptoms, and seizures. They found that symptomatic patients at the time of diagnosis compared to asymptomatic patients at the time of diagnosis, where this was just, and brain met was incidentally found on screening, were more likely to present with metachronous brain mets, larger brain mets, and more frequently received surgical resection. They also found that individuals who presented with neurological symptoms had a shorter survival time. It was an independent prognostic factor in terms of survival time. And they suggest that prognostic schemas should include neurologic symptoms as a component of that, so that you could adequately stratify patients. Two different types of neurologic symptoms were also pulled out of this analysis, specifically focal deficits and neuropsychological symptoms, and both of those were found to be statistically significant in terms of predicting overall survival time. When we've studied newly diagnosed brain metastasis patients with neuropsychological measures, we find frequent cognitive impairment at the time of diagnosis in the vast majority of patients who have multiple metastases, most frequently in the cognitive domains of memory, processing speed, and executive function. And these cognitive impairments are correlated with quality of life, specifically social function, functional abilities, and physical well-being. and they are also an independent predictor of survival time. In the early 2000s, Christina Myers was a part of a clinical trial that allowed us to measure lesion volume and associate that with cognitive function. And what they found in that study was that cognitive function was correlated not with the number of brain metastases, but with the volume of brain metastases. More recently, Schimmel, in a smaller but methodologically robust study, did not find this association. And I think historically we've all thought that just lesion burden is probably the largest or perhaps even the only contributor to cognitive dysfunction. But very recently, Manuel Valiente's lab in Madrid, using a cancer neuroscience approach and looking at neurophysiologic signatures, found that brain metastases have the potential to modulate neuronal communication. And this was independent of tumor size, and this occurred both in IPSI and contralateral neural circuits. So it may be that this cancer nervous system crosstalk is also impacting cognitive function, irregardless or irrespective of tumor size. As we think about how we treat our patients, it really requires multimodality CNS-directed treatment strategies with the ultimate goal of controlling the brain disease without toxicity and extending life while preserving function and quality of life. And this requires a lot of work to try to identify the right treatment for the right patient. And we're going to hear a lot about this today. I know we're going to hear about advances in diagnostics and advances in treatments. But I want to talk a little bit about some of the work that we've done looking at the effects of radiation therapy and improving radiation therapy's delivery to minimize toxicity and maximize oncologic response today. So as we know, the pathogenesis of radiation damage involves very early processes that are often neurodegenerative in nature, including vascular endothelial damage, inflammation and microglial dysregulation, oligodendrocyte injury, neuronal damage and altered neurogenesis, and epigenetic aberrations. There have been a number of risk factors that have been identified over the years, including some radiation treatment factors that are probably well known to this group, the use of prior or concomitant chemotherapy, treatment delivered to the very young population or very elderly population, particularly in those who have other past medical histories that include vascular comorbidities or diabetes. And there have been some work identifying germline SNPs that seem to place individuals at greater risk for cognitive dysfunction after treatment, including the ApoE4 allele and SNPs in COMT, BDNF, DTN, BP1, and other molecular genetic pathways. So this understanding of some of the ways in which radiation can adversely impact brain and cognitive function have led to studies that have examined different ways of treating brain metastases, moving from whole brain to stereotactic radiosurgery, for example, using some advances in radiation delivery to avoid certain target regions, and also using pharmacologic approaches to try to neuroprotect the brain. And I'll review the studies that support these approaches. But ultimately, if we want to study patient-centered outcomes in clinical trials, we require some tools to be able to do that. And we have to decide what clinical outcome assessments or what aspects of patient outcome we're really interested in. And when we think about the impact of the disease and treatment on the patient, I think of the most broadest outcome that we could measure as being health-related quality of life. And this, of course, incorporates impacts from disease and treatment, but it incorporates a lot of aspects of our lived experience. It could include the election results or financial toxicities or our marital relationship or other relationships that we have. So those would be non-specific to the tumor and treatment and may not be the optimal outcome for a clinical trial looking for a difference between two treatments that are being studied in a randomized clinical trial. We could move to something that's more proximal to the patient, things like symptoms that are reported, and those symptoms may be far more specific to the brain, such as headache or fatigue, perhaps. And all of these sorts of outcomes would be considered patient-reported outcomes and would require the use of questionnaires. I would argue that the most proximal outcome that we could look at to the brain and brain-directed therapies are impacts on cognition and brain function, and things like memory function, language function, executive function. And these are called performance outcomes in FDA parlance, and those are best measured by cognitive tests and not questionnaires. As I said, the FDA calls these outcomes clinical outcome assessments. These are not meant to be things like overall survival time or response rates. They consider cognitive tests to be a performance outcome, and we've designed a clinical trial battery that we've used in many of these clinical trials. The FDA is generally interested in how an intervention improves how patients feel, function, or survive, and performance-based outcome assessments or cognitive tests fall in the category of measuring function. And the FDA has defined a performance outcome as a measurement based on standardized tasks actively undertaken by a patient according to a set of instructions. And they provide specific examples of cognitive testing as a representative performance outcome measure. So the clinical trial battery that we have come up with and have integrated into many of these studies requires about 30 minutes for patients to complete and involve 3 different measures that assess episodic learning and memory function, executive function, and processing speed. This battery has been endorsed by the International Cognition Cancer Task Force and recommended by the Response Assessment in Neuro-Oncology for integration in not only brain metastasis trials, but also glioma trials, and also as a backbone of clinical research in non-CNS cancer research. So we explored some of the characteristics of this really abbreviated cognitive assessment in relationship to a much more extended neuropsychological evaluation that would occur in our clinic in the same patient population. And we found that using just these 3 tests, we found high rates of agreement with clinician-diagnosed cognitive impairment from the 2 to 3 hour neuropsychological assessment. And we found that that brief clinical trial battery scores and tests correlated with the full 2 to 3 hour cognitive evaluation, as well as patients' level of functional independence and clinicians' rating of their Karnofsky performance status, but really was not impacted by mood variables, again, demonstrating the independence of these cognitive tests and the identification of cognitive impairment from mood states. So as we've applied this in a number of clinical trials, one of the first that I wanted to mention today was a small study that we initiated here under the guidance of Eric Chang, MD-ACC ID 00377, in which patients with 1 to 3 brain metastases were randomized to SRS with or without whole brain radiation therapy. And using a Bayesian design and a very small sample, we were able to demonstrate that there was increased rates of neurotoxicity associated with the inclusion of whole brain radiation therapy. This was confirmed in the larger NCCTG study led by Paul Brown, and really led us to conclude that despite better intracranial tumor control with whole brain radiation therapy, patients that were treated with the whole brain were at greater risk for cognitive decline. And this really led to the start of a lot of changes in the standard of care of treatment and reconsidering outcomes in this space. But we know that some patients are going to require or will prefer whole brain radiation therapy. And we wanted to know if we could protect the brain when delivering whole brain. So RTOG 0614, led by Paul Brown, we randomized patients to memantine or placebo and monitored them over time. And we found that in patients who received memantine with their whole brain radiation therapy, that it delayed time to cognitive decline. There were no differences in self-reported cognitive concerns and no differences in quality of life. We also found in that study that if you were an ApoE4 carrier, that seemed to prognosticate increased risk for memory decline after whole brain radiation therapy, which was what I believe to be a practice-enhancing finding. Moving on to NRG CC001, there became increased interest in delivering whole brain radiation therapy differently and combining that with a pharmacologic approach of memantine. And Vinay Gandhi, through his work on studying and developing hippocampal avoidant whole brain radiation therapy, led this study in which patients were randomized to whole brain or hippocampal avoidant whole brain radiation therapy with memantine. And again, we demonstrated that hippocampal avoidance prolonged the time to cognitive decline and was not associated with any worsening of intracranial PFS or overall survival. A secondary analysis of white matter integrity as an imaging biomarker of cognitive decline has been led by Dr. Bovi. We heard him mention this earlier. And what he did is he explored a subset of the patients that had longitudinal imaging and cognitive test results available, and very meticulously traced brain volumes, white matter volumes, and MET volumes, and demonstrated that the mean flare volume by arm and time point increased in the whole brain arm more than the hippocampal avoidant whole brain arm, and that increases of white matter damage after whole brain radiation therapy at 6 months was associated with declines in cognitive function, including the global clinical trial battery composite score, as well as on measures of processing speed and executive function. leading to some really interesting hypotheses about how we can use measures of white matter integrity, for example, as predictors of risk and as imaging biomarkers of cognitive decline. The use of avoidance techniques in whole brain radiation therapy has grown, so the interest in this has grown. There's been some studies that are looking at avoidance of certain corpus callosal structures. And at Ohio State University, I believe they're finishing up a phase 2 study that has explored the use of what they're termed memory avoidance whole brain radiation therapy in patients with more than 15 brain metastases. And in this technique, they specifically avoid the hippocampus, the amygdala, the corpus callosum, and fornix structures that are involved in a memory complex that goes beyond just the hippocampal region itself. And a sample memory avoidance treatment plan is seen here on the right, where you can see these regions carved out of that treatment plan. The results of this are not available yet, but I think it's very interesting to consider how avoidance delivered radiation therapy may evolve in the future. I also wanted to mention an ongoing SWOG study called Maverick, MRI brain surveillance alone versus MRI surveillance and PCI, a randomized phase 3 trial in small cell lung cancer led by Chad Rustoven and Paul Brown, in which patients receive longitudinal cognitive testing. And what I want to share with you are the ability of us to integrate these outcomes into very large studies and to collect this data on patients with a high degree of fidelity. So up to this point in time, as of the fall of this year, a couple months ago, 479 sites have activated the study. We've trained and certified close to 650 test administrators. 235 patients have enrolled. 203 patients have been tested. And that has yielded 4,546 tests that have been centrally reviewed and scored. And this is a snapshot of those characteristics. And we can see that of those patients who completed testing, close to 99 to 100%, even up to 720 days later, 97% are completing these tests reliably. So this is definitely feasible. The most common reasons that tests are not initiated in about 13% of patients are things like scheduling difficulty, the patient's died, patient's too ill, institutional errors, neurologic disability, or reasons that we don't know. And then the next most common reason are patient refusal. And the reason that tests are not complete, most commonly, although very rare still, is an institutional error. Something came up where they either forgot to do it or they misadministered the test with the patient. So this, I think, gives us a lot of hope about the feasibility of doing this and that we're able to integrate this in the studies, get good return on this investment, and hopefully continue to lead to some practice-changing outcomes. The last thing that I want to share with you is more reasons for optimism. Verhaken colleagues out of the Netherlands have been following brain metastasis patients treated with gamma knife radiosurgery, and they had a cohort, albeit a small cohort, of long-term survivors with brain metastases that they had serially monitored cognitive function and quality of life in up to 21 months after gamma knife radiosurgery. And what they found in these very long-term survivors was that they were exhibiting relatively stable cognitive function and relatively stable or improved quality of life. So I think the efforts that we're putting forward to improve the therapeutic window of our treatment delivery are really yielding fruit, not only acutely, but also in this smaller subgroup of very long-term survivors. So I encourage you all to continue doing that work moving forward. And thank you for inviting me to be a part of this conference.
Jeff, that was just a great talk. Thank you so much for sharing with us. I know I have a couple of questions, but just to remind the rest of the group and for those of us, obviously, that are joining us online, please use the chat box function to write your questions down. We're going to just move on to the next speaker, but we'll have a panel discussion at the end of this first session this morning, and we'll get to as many of those questions as we possibly can. So if you write the questions in the chat box, we'll make sure to address those during the panel discussion. And with that, I'd like to have Dr. Krukoff please introduce our next speaker.
Good morning, everyone. My name is Max Krukoff. I'm one of the neurosurgeons at the Medical College of Wisconsin in Milwaukee. It's my distinct pleasure to introduce Dr. Schminda. Dr. Schminda is a professor of biophysics and radiology here at MCW. She started her undergraduate training at Marquette University, where she studied biomedical engineering, and then got an MS and PhD from MIT's Department of Electrical Engineering, and then did a joint PhD with Harvard and MIT in their health science and technology program. After her postdoc at Mass General, she came back home to Milwaukee, where she's been working as faculty. Dr. Schminda's research focus has been the development of clinical advanced MRI techniques to evaluate primary and metastatic brain tumors. She's published quite a few seminal papers on the topic of perfusion and multiparametric MRI. She's been awarded US patents and developed technologies, as well as started companies. Her perfusion MRI approach was chosen as the basis for several ACRIN multicenter clinical trials. In 2016, she was elected to the American Institute of Medical and Biological Engineering College of Fellows, and in 2020 was elected as Fellow of the International Society of Magnetic Resonance in Medicine. She's co-founded two companies, Prism Clinical Imaging and Imaging Biometrics, both of which have resulted in several FDA-cleared imaging analysis platforms. And she's mentored several medical and graduate students, and I would add young attending physicians as well, like myself. So it's my distinct pleasure to hand it over to Dr. Schminda.
Thank you, Max, for the kind invitation and introduction, and to the panelists themselves. So I will share my screen here. All right. So yes, I'm going to talk to you today about a new biomarker called fractional tumor burden that's derived from perfusion MRI technology. Here's the declaration of my conflicts of interest. And just jumping into the clinical challenge we have with treatment surveillance using MRI for both primary and metastatic brain tumors. I think everybody's well aware of the fact that with conventional MRI techniques, it's really difficult in many cases to distinguish radiation necrosis from recurrent tumor. In this case shown here, after stereotactic radiation radiosurgery. And at right, you can see both the FLAIR and the T1 post-contrast images look the same for these two patients. However, upon surgical diagnosis, you find that one is actually treatment effect and the other is a tumor progression. So the challenge again is, how do we distinguish the two on standard imaging? It's difficult, yet there's a lot of evidence that perfusion-based MRI techniques that give us maps of relative cerebral blood volume, so show us kind of the vascularity throughout the brain, can help with this distinction. So at left, you see again two different patients, both have post-contrast lesions that are enhancing. But if you look at the relative cerebral blood volume, or RCBV maps at right, you can see one is very cold and the other one definitely has a higher level of hyperperfusion, as we call it, or high levels of RCBV. And so there's a lot of evidence in the literature that RCBV can be used to distinguish tumor from treatment effect. But the challenge has been what is that threshold? People often, because sometimes you can just have subtle hyperperfusion and it's hard to make the distinction of tumor from treatment effect. And part of the challenge in this field of study has been that there have been many different reported cutoffs of RCBV, what's shown here in the highlighted pink at the right. And so anywhere from a range of, close to 1 to, close to 2.5. And a lot of this variation has been attributed to all these different studies who have collected RCBV information with different imaging settings of TR, TE, and flip angle, and therefore, they come up with different thresholds of distinction. Because of this, a group was convened a few years back to try to come up with a consensus acquisition approach. This was spearheaded by the FDA and the Jumpstarting Brain Tumor Coalition. Several of us who participated in this recommendation are shown at the bottom. and came up with a consensus recommendation on how best, or the recommended options of how best to collect this information. So we have a national consensus so we can begin to compare our results, across the board. And this recommendation also was then adopted for brain metastases also, as shown here. Now, this is really a good first step because it gives us a consensus acquisition approach. However, even if we all collect the data the same, there's still an issue because each study that this acquisition is used for is comprised of different patients. So you're going to come up with different mean values of RCVV. So again, the same challenge of how do you come up with the right threshold to make this distinction? And so the solution here is to actually determine on a per voxel basis, if the RCVV is consistent with tumor or treatment effect. And this is where we performed a study with spatially matched biopsy samples to make this distinction. So again, to emphasize this point, at left you see here this area. This is a glioblastoma patient. You see a lot of heterogeneity in the RCBV. And so it's actually, in most cases, an admixture of tumor and treatment effect. Rarely do you get one or the other. And because of this, we need that study of spatially matched tissue biopsies to make the distinction. And this is what we performed, a study where we had intraoperative screen captures of the site of the tissue sampling that were registered, of course, to the SPGR, the 3D MRI image, and then registered to our RCVV maps. And this study was published in 2018 by our group, much due to the efforts of Dr. Mueller, neurosurgeon at MCW. Melissa Pra was the author, engineer, and our person who manages the tissue procurement. And again, you can see here, so the intraoperative screen capture of the biopsy location in all three orientations registered to the Stealth SPGR, which then was registered to our ARP CVV. So with this information, we could come up with a specific threshold to distinguish treatment effect from glioblastoma. And we did this for both what's called normalized RCVV and also standardized RCVV, a method I'm not going to get into, but it actually gives us more consistency in our measures of relative cerebral blood volume. So what we found here again is a good distinction, a significant distinction between treatment effect and GBM, but there's still, you can see some ranges here. So we further declared different levels where the lower 95% confidence interval of GBM RCBV gave us one threshold. The upper 95% confidence interval of the non-tumor or treated tissue gave us another threshold. And what was really nice about the study at MCW is it actually matched an independent study performed by a colleague at Mayo Clinic in Arizona, Dr. Leland, who a close collaborator. And he found the same threshold using the same acquisition approach to distinguish tumor from post-treatment radiation effect. So again, this is the most important threshold, is this distinction between treatment effect and tumor. So then we can routinely generate what we call fractional tumor burden, and the generation of these maps is as follows. First, we use what's called delta T1 maps. Now what these are, I'm not going to get into the details of these, but these are calibrated difference maps between the post-contrast image and the pre-contrast image. And because they're calibrated difference map, they give us the true contrast enhancement, so it's not confounded by a bright signal on pre-contrast imaging. And also because it's quantitative, we can draw a rough bounding ROI around the region of interest and apply a threshold that applies across patients, time, scanner vendors, and we get that region of enhancement. Then within this region of enhancement, we look at the RCBV levels, and using the thresholds we determined, we create what's called fractional tumor burden maps. So with the contrast enhancing lesion, you can see these three regions of high vascularity, high probability of vascular tumor, high grade tumor, compared to the intermediate, compared to the region is most likely just non-tumor treatment effect. And here's an example of what we routinely actually generate now at the medical college, where again, you can see at left the post-contrast T1 weighted imaging with, clear enhancement. And you can see here with the fractional tumor burden maps, the range of vascularity and treatment effect across the slices. And this, makes sense. All tumors are typically some admixture of the two. So as further validation of this method, a prospective study was carried out by Dr. Hu at Mayo. I participated in this study. And this was a beautiful study because a lot of effort was put into, again, prospectively validating the FTB thresholds. So FTB in this particular study was defined as the percent of tumor voxels with RCBV greater than that lower threshold of 1. And so that, if you look at the images at right, that's the yellow plus the red regions. And what's really nice is he had a very motivated neuropathologist who determined for each surgical sample the actual percent of histologic tumor burden. So if you look at the examples here, the histologic tumor burden, here in the biopsy sample was 0%. And if you look where the sample was taken from, the actual FTB, the red plus yellow region, was just 0.88 of the entire lesion. If you look at the other extreme where the histologic tumor burden was 90%, and you look at FTB and it had a value of 0.88. So it was a nice validation of the FTB method. They looked at the accuracy of predicting greater than 50% of tumor content in a sample versus 80%. Excellent accuracy for both the different types of RCBV, both normalized and standardized RCBV. Here at the Medical College, we also had this really nice case that was reported by Dr. Conley, neuro-oncologist at Medical College. And this is a case pre-surgery in a patient with glioblastoma who was going back for repeat surgery. And you can see, of course, the progressing enhancing lesion 4 months post-CRT. And then after surgery, post-surgery, there was a very nice resection, but some residual tumor left. It could not be removed because of the location. And what was really interesting about this case is intraoperatively, the neurosurgeon said it was very vascular, consistent with recurrent tumor. And then the neuropathologist report came back as no tumor present, necrotic brain tissue, fibrous tissue, and thick-walled vessels consistent with treatment effect. So one of these very confounding situations. But if we look back and we retrospectively look back at our FTB map, they were both right. So you looked at the enhancing tumor was largely comprised of non-tumor treatment effect tissue. And interestingly, the part of the tumor that was remaining, that small smidgen of enhancement, actually was comprised of red and yellow regions on FTB consistent with higher vascular tumor. So then Dr. Conley asked the question, well, I wonder, how this patient progressed. So if we focus on these two regions of residual high signal on FTB, we look at these two slices, we see that in that area where the FTB was yellow and red, that was the site of the most aggressive progression for this patient over the next 7.5 months. Also, Dr. Michael I. from Stanford has been publishing some really nice papers on the clinical utility of FTB. And this is one of his first papers to demonstrate that increase the diagnostic confidence of the neuroradiologists and then the brain tumor board team. And this is two of his examples, a patient with treatment effect, where you can see in this histogram of the voxel values that it's largely treatment effect, versus a patient with recurrent tumor where it was comprised of the majority yellow plus red regions on FTB. And so he also looked at, did perform tissue confirmation and found excellent accuracy of the FTB maps, especially when you look at the higher or the vascular region of FTB. Now, in the clinical rating of this, there was 3 neuro-oncologists, a radiation oncologist, and a neuroradiologist. They recorded if they thought tumor or treatment, if it was tumor or treatment effect, or whether they would change treatment based on FTB. And the consensus decision was change treatment in 93% of the tumor cases and not to change treatment in 75% of the cases based on FTB. So a really nice clinical utility demonstrated here in this particular study. The thing that we're exploring now too is with FTB, can we be more specific, because it's always going to be an admixture of tumor and treatment effect. does it rise to a certain volume of tumor that would have clinical significance, and when you would know specifically, okay, this is when we should intervene, treatment should be changed, the patient should go back to surgery, whatever the question might be. And so we're beginning to look at the volumes of these different segments on the FTB map. And sort of as a teaser of how this could be important, we have this case where the FTB volume, again comprised of the red plus yellow, is quite small, just 1.83 cc's, and the overall survival is quite good of 25 months, and this is a glioma patient, as opposed to one with a higher fractional tumor volume with a much lower overall survival. So looking again, these are glioblastoma, and looking at patients stratified by methylation status, which is well known to be a predictor of outcomes. So we looked at our particular population if we saw this difference also. So at left here, you can see those with methylated MGMT have a longer survival compared to unmethylated. So consistent with what we know, what's in the literature. But if we look at the utility of FTB to further stratify these patients, if we focus just on the unmethylated patients, we find that it actually can be further stratified depending upon whether that FTB volume is low or higher. And what's interesting too is with those with a low FTB volume, that red plus yellow volume, the survival begins to approach what we see in methylated patients. So an interesting predictor of possible outcomes. And just an example, here's a methylated subject compared to unmethylated subjects with a low and high volume of a fractional tumor burden, and we see a significant difference in their overall survival, again approaching what we can see sometimes in methylated patients. Okay, so that was a lot of our studies have been for application to gliomas, glioblastomas in particular. But what about using FTB for brain metastases? Now, I was a little hesitant on this study that used FTB for brain metastases because remember, as I showed in the earlier slide, we have validated the thresholds used for FTB for high-grade glioma, so vascular high-grade glioma. And so I wasn't sure if it would be as applicable at this stage before we validate it for brain metastases. But in another nice study coming from the group of Michael Ive, he showed, in fact, by using the same thresholds that he used for primary brain tumor, it also was predictive of tumor progression in patients with brain metastases treated with stereotactic radiosurgery, and again found some excellent accuracies. He further subdivides the different FTB volumes, and that's still sort of up in the air, like, what it should be. What seems to work best is just looking at red plus yellow versus the blue volumes to predict outcomes and predict progression. But still, since we, have not previously validated these thresholds for brain metastases, we're in the process of doing that. So step one for validating these methodologies for brain metastases, we started by just looking at RCBV in patients with untreated brain metastases. And just recently published a paper, it's just coming out in AJNR. And in this paper at left, you can see here this graph similar to the earlier one I showed, where there's a lot of different ways that people would collect and process the data, which can sort of explain in large part why different people are getting different RCBV values in brain metastases. And again, because of this consensus protocol, we're now recalibrating RCBV using the consensus protocol to see if, number one, can we assume that in brain metastases, that perfusion, the RCBV levels, is going to be greater than reference brain? First of all, can it actually just help to identify brain metastases? And we found that it's a smaller study, but with multi-sites, Mayo and USC, we did find in all brain mets, we definitely see a higher vascularity compared to normal appearing white matter, a little bit lower overall compared to GBM. But then if we divide out the individual primary histologies, we definitely see that RCBV does show hyperperfusion and can be a good diagnostic tool. Our next step, of course, is then to further validate the thresholds used for FTB. All right. So the final application that I'm quite excited about that we're just in the process of starting is this study with Dr. Krukoff, and it's using FTB for biopsy guidance. And shown here is a case of a 50-year-old female patient with metastatic small cell carcinoma. And at left, you see the contrast enhancing region. This is within the brain lab neuronavigational system. And I highlighted here kind of the trajectory of the biopsy. And the pink area here is just the sample, the tissue sample that would be accessed for diagnosis based on the biopsy guidance. And what you see, this is not FLAIR, but FTB at the right, what you see in the images at the right is along the trajectory, you definitely have a variation in what's tumor and what's treatment effect. So it begs the question of you really want to use this information to try to optimize the diagnostic yield from the surgical biopsy sample. And if I expand this even more, if that was hard to see, you can see here again, you have a large region of contrast enhancement. And then if we zoom in here on the FTB, you can again see that where you actually sample can make a difference in the yield of your diagnostic sample. And actually, sort of hot off the press right now, we've done a study. We've done this in about 17 patients, and just analyzing what the accuracy of FTB is for directing it to tumor tissue, and something we're just working up to submit as an ASNR abstract. We found in the initial study of 17 patients an accuracy of 0.89, a positive predictive value of the same 0.89, and a negative predictive value of 0.86. We only found in a couple biopsy samples where it looks like it was less good is where it looks like the spatial sample was from an area where we actually didn't have FTB values in non-enhancing regions. So definitely excited about the potential here. This is also going to help us, again, prospectively validate the levels of the RCB thresholds that we're using to create FTB for brain metastases. So a lot of good things coming out of this study. All right, so in conclusion, I hope I convince you that fractional tumor burden can distinguish tumor from non-tumor or treatment effect, and definitely in primary high-grade tumor. This is not a technique for low-grade avascular tumor, but also for metastatic brain tumor. One thing that's important to know is that the underlying RCBV methodology is robust, with the national consensus for data collection that has now come out for primary and metastatic brain tumors. So we should see a lot more consistency across the board for these types of analyses. And growing evidence in the publications I reviewed for use in treatment surveillance. I think this can be a really important part of just making that distinction of tumor versus treatment effect. And prospective validation is underway to determine the clinical impact and the accuracy for biopsy guidance, as I just mentioned. And future is to look maybe more specifically at the implications of the specific fractional volumes, and if they too give us more information on outcomes and impact. Thank you.
Thank you so much, Kathleen. As always, just an amazing talk. So much to unpack there. Your data just continues to get better and better, and it's exciting to see that, perhaps we're moving closer to validating tools for imaging in the absence of biopsy. That's just really great to see. It really is my distinct pleasure to introduce Dr. Vinay Gandhi. Dr. Gandhi completed his medical residency training actually at the University of Wisconsin. He went on to become professor of radiation oncology at Northwestern, where he currently serves as the director of the Brain and Spine Tumor Center at the Northwestern Proton Radiation Facility in Warrenville. His pioneering research on strategies to minimize the cognitive impact of radiotherapy has absolutely changed all of our clinical practices as radiation oncologists. And we really look forward to hearing his talk today about his most recent study evaluating brain radiotherapy and small cell lung cancer and the implications of recently published modern clinical trials. And so with that, it's like I said, it's my distinct pleasure to introduce my good friend and colleague, Dr. Gandhi. Thank you so much for joining us this morning, Vinay. I think you're muted still.
Thanks, Joe. You're right. I was muted. I was trying to find the unmute. I'm not a WebEx person.
That's
But
okay.
that was a generous introduction and a pleasure to be part of this wonderful meeting. I was asked to speak on this topic, reevaluating brain radiotherapy in small cell lung cancer, implications of modern trials. These are my disclosures, but probably my most significant disclosure for this meeting is that, as Joe may have mentioned, I am a proud Milwaukee native and a Wisconsin native and a diehard Packers fan. So all Bears fans can start exiting the meeting if they would like at this time. So I was asked to speak about prophylactic cranial radiation. So let's set the groundwork for that. So why do we even think about brain radiotherapy? Why is radiotherapy to the brain so important? Well, very basically, there's no blood-brain barrier to radiotherapy, right? So we understand the blood-brain barrier is something that has developed over human evolution. It prevents penetration of some systemic agents, those that are effective against small cell carcinoma, to the brain. And this is different than drug therapy in the sense that drug therapy can be very effective for small cell carcinoma in treating the body, but then the brain, in some cases or many cases, becomes unaddressed. And so that's why brain radiotherapy has become such an important component to what we consider for small cell lung cancer patients, not just in terms of their survival, which, in the control of the body and the brain impacts survival, but to some extent also their quality of life. Our ability to control brain disease typically has a greater impact on patients' quality of life. We know this, and I think Dr. Glitza did a great job really helping explain how that's relevant in the melanoma world, but it's also relevant in the small cell world, where patients can have a large mass growing rapidly in the lung, and it doesn't necessarily impact their quality of life, but a large mass or a mass growing rapidly in the brain can impact their quality of life meaningfully. So decades ago, a long time ago, well before I was born, we started developing this approach to whole brain radiotherapy. It's a very simple thing to do. It can be even delivered with a Cobalt-60 machine. It's very simple. It's just two lateral beams that focus on the skull and therefore the brain. And we developed doses that were based on some preliminary radiobiologic literature, which is when we treat therapeutic whole brain radiotherapy, or WBRT, we treat to 30 gray and 10 fractions, because we believe, it takes almost 1 billion cells for something to show up on a brain MRI or a head CT, that's the amount of dose that we need to do to deliver to try to control grossly macrometastatic disease. Whereas we're looking in the prophylactic cranial radiation, meaning we know there's disease up there, but it hasn't reached that 1 billion cell threshold, then we're thinking, hey, we can get away with doing a lower dose of 25 gray and 10 fractions. That's where the dose for prophylactic cranial radiation arose. But the approach is the same. It's just two laterals, just a difference in dose. And this approach has been used for decades. It's been shown to be quite effective in palliation in terms of shrinking gross disease. It's available everywhere, wherever there's a radiotherapy facility across the world. And it's super easy to deliver and plan. It can even be done. Yes, radiation oncologists do work on weekends. It can be done on a weekend very simply. And we do know that when we deliver it, both in the therapeutic setting for gross disease and in the setting of prophylaxis, and where we can't see gross disease, we do limit the likelihood of other mets developing in terms of micromets becoming macrometastases. So let's build off of that. So there have been a number of trials decades ago that tried to understand the role of prophylactic cranial radiation for small cell lung cancer. These trials have come under a lot of scrutiny recently, and we'll cover that a little bit. But the first was a meta-analysis. It was a meta-analysis of a number of different prospective trials for limited stage small cell lung cancer. And what they observed was that the use of prophylactic cranial radiation reduced the incidence of brain metastases in our small cell lung cancer patients, and importantly, actually improved their overall survival. A 5% overall survival benefit at 3 years was roughly, at that time, the same kind of overall survival benefit that was achieved when we added chemotherapy to thoracic radiotherapy. in the setting of extensive stage small cell lung cancer. So limited stage is what is deemed to be confined to one radiotherapy port, or deemed to be confined to one thorax or hemithorax. Extensive stage is thought to be disseminated beyond that. And we observed in an EORTC randomized control trial, which has come under some scrutiny, but there was a reduction in the number of brain mets, same idea, and a survival benefit of 14% at 1 year. Now, the challenge with this is people have scrutinized this because not all patients were appropriately staged up front. This trial was done decades ago. It wasn't in the era of MRIs, and certainly it's come into question in contemporary management. But this was the baseline behind which prophylactic cranial radiation became considered a standard of care for small cell lung cancer patients. And here's that survival benefit. Now let's look at contemporary data. Well, in the limited stage setting, we have a contemporary meta-analysis that showed that PCI, using all the data that we have recently, seems to offer a survival benefit for limited stage. 24% at 2 years is quite a survival benefit. So one raises some questions. Okay, is this really real, or is there some selection bias? We're looking at retrospective and prospective data. But there is one study, a similar meta-analysis to what was done decades ago, that shows a survival benefit for limited stage small cell lung cancer. However, in the extensive stage small cell lung cancer, there is a prospective randomized trial that came from our colleagues in Japan. And I'm sorry, I have the wrong reference listed here. But that showed that PCI did not have a survival, did reduce the risk of brain metastases, but it did not have a survival benefit. And the importance about this trial, as many of you know, is that the control arm and the experimental arm, the arm that got observation versus prophylactic cranial radiation, all underwent MRI surveillance, with the idea that we're able to capture brain metastases much more sensitively at baseline, and therefore they wouldn't even be eligible for this trial, and during the course of observation, so that early intervention can be used. And in that setting, it raised the question as to whether PCI really contributed that survival benefit that we had seen decades ago in a randomized controlled trial. So now we have come to a point where we say, okay, we're not sure about the benefit of prophylactic cranial radiation. We have some contemporary data suggest that it may not provide the survival benefit. But what about the downside? And the downside that we think about is toxicity, and specifically cognitive toxicity. And to be quite honest, it's not very clear what the cognitive toxicity of PCI really looks like. Well, we ran a trial of non-small cell lung cancer, locally advanced non-small cell, a couple decades ago, RTG-0214. This trial was a phase 3 trial of prophylactic cranial radiation versus observation for non-small cell lung cancer. And unfortunately, it didn't reach a completion of accrual because it did not get a lot of support and enthusiasm in the field. But what it did show is in the limited patients that they did enroll, that prophylactic cranial radiation led to a higher risk of certain domains, memory-related domains, the Hopkins Verbal Learning Test, recall, and delayed recall, having greater decline at 3, 6, and 12 months. So that's sort of brought into some consideration that, hey, when we think about PCI in general, in the small cell world, maybe this too could be associated with cognitive toxicity. And so we tried to explore this a little bit more. We actually took RTG-0212, which was a randomized trial a couple decades ago. We were randomizing between standard dose prophylactic cranial radiation and dose escalated prophylactic cranial radiation, something we probably would never consider doing now. But what we observed that is even in the standard dose of 25 gray and 10 fractions, there was still a 62% rate of chronic cognitive toxicity and a 29% rate of decline in the memory-related domains at 6 months. We then said, okay, why don't we take the non-small cell data with the small cell data and put it together in a secondary analysis where we tried to compare patients who received PCI for both small cell and non-small cell to those who received observation only for non-small cell. And we found that PCI was associated with the increased risk of Hopkins Verbal Learning Test memory decline and also decline in self-reported cognitive functioning. But it's a really messy study if you think about it, because we're combining small cell and non-small cell in one arm and only looking at non-small cell in another arm. And it's messy because we understand that small cell lung cancer patients are different at baseline in their cognitive domains. This came out of the MD Anderson team. They found that about roughly half of patients presented with impaired cognitive functioning prior to undergoing PCI. And when they controlled in this retrospective analysis for disease progression, they found no cognitive decline after PCI. But they did appreciate that there were other factors impacting cognition: cigarette smoking, chemotherapy, disease progression. So a lot of confounding factors that make our understanding of the cognitive effects of PCI a little bit challenging and perhaps a bit confusing. So the question is, do we see cognitive toxicity with PCI, and have we established that? Well, in spite of that, we decided within our research team to say, hey, we can do better. Let's try to make PCI safer. And we looked at an approach called hippocampal avoidance. So it was based on the idea that we know that the hippocampal dentate gyrus houses a compartment of highly exclusively radiosensitive neuroregenerative stem cells that are also cognition specific. And we had some preclinical and clinical evidence that the hippocampal dentate gyrus in this neurostem cell compartment is quite important to memory-related function after radiotherapy. And so we developed this technique where we use intensity modulated radiotherapy to essentially deliver whole brain radiotherapy doses, in this case in the PCI setting, 25 gray and 10 fractions, but then carve out the centers where these dentate gyri and neurostem cells reside, and essentially significantly lower the dose. It's not truly avoiding completely, it's still getting some low dose, but lower the dose and lower the dose per fraction delivered to this mitotically active neurostem cell compartment. And by doing so, we hypothesized that we would be able to preserve typical neurostem cell activity, which is to develop hippocampal neurogenesis and thereby maximize and preserve cognitive functioning in our patients. So from that, we actually first started doing this and evaluating it in the setting of whole brain radiotherapy, which is therapeutic whole brain radiotherapy for brain metastases. Again, 30 gray and 10 fractions. And we found that for intact brain metastases, we were actually had a number of positive trials that hippocampal avoidance was actually preventing cognitive toxicity. We showed it in our Energy CC001 trial. We have a similar trial in Taiwan, a randomized trial that also found a benefit. And then there was a single arm phase 2 trial from UT Southwestern. The summation of all of that led to the widespread adoption of hippocampal avoidance during whole brain radiotherapy for patients who had brain metastases and are receiving whole brain radiotherapy. But the sister trial to Energy CC001 was this trial in the setting of prophylactic cranial radiation. This was a randomized phase 2/3 trial of PCI with or without hippocampal avoidance for small cell lung cancer. Patients were stratified by stage, age, and whether they received memantine as a neuroprotectant. And they were randomized to PCI, conventional laterals, 25 gray and 10 fractions, versus hippocampal avoidant PCI, 25 gray and 10 fractions using IMRT. While we were developing this trial, we actually had some conflicting data coming from Europe. So we had the first trial, a much smaller trial of 150 patients from Spain called the Premier trial. And they did the exact same thing we were doing: standard PCI versus hippocampal avoidant PCI. And they used a different cognitive test than we've used, but it's similar. It's a delayed recall on free and cued selective reminding tests at 3 months. And they observed the patients who received hippocampal avoidance actually had greater preservation of their memory function at 3 and 6 months, and even up to 12 and 24 months. And there was no difference in intracranial relapse rates and overall survival. However, around the same time, the Dutch came out with their own trial, the NKI trial. And quite frankly, it was a mirror image of our trial, Energy CC003, but a much smaller sample size of 168 patients. And they found no benefit to hippocampal avoidance in terms of the Hopkins Verbal Learning Test. They actually found that overall cognitive toxicity was higher in the patients who received hippocampal avoidance, and there was no difference in intracranial relapse rates and overall survival. So this NKI trial really stood in contrast to numerous trials that had been conducted that showed a benefit to hippocampal avoidance. And it was the one sort of contrarian trial to all of that data. It's important to understand, though, that there's some limitations to the Premier NKI trial. So number one, there was actually no central quality assurance of hippocampal contouring or IMRT planning on these trials. So on the right, I've given some examples of patients who were enrolled on our energy oncology trial, CC001 or CC003. And as part of our trial, we mandated central quality assurance. And we actually ensured that we were reviewing them. Actually, Dr. Bovi was one of our reviewers within a day or two of them submitting their information and tried to correct any problems. And in some cases, we would correct them, and actually then they would change their plan and be able to deliver. So we really tried to manifest quality assurance to ensure that what we're doing is accurate. So here's an example of a patient who was enrolled on one of these trials. So purple is what was submitted by the treating physician as their hippocampal contour, and orange is the actual hippocampal dentate gyrus. And you can see they're missing a significant proportion of the hippocampus to be able to spare that area. Here's another one. So again, purple is a treating physician contour, and blue is the actual hippocampal dentate gyrus. And in this case, they're missing a significant portion of the head of the hippocampus. And here's a third situation where the purple, again, is the treating physician contour, and blue is the actual dentate gyrus. And they're missing roughly 50% of the dentate gyrus in terms of our ability to spare. So these are patients who were actually enrolled on trial, but these plans were never delivered because we were able to correct it and ensure that there was high quality of treatments for what we needed to do. The second limitation is that both of these trials had a limited sample size, roughly between 150 and 168 patients. Our trial in Energy CC003 was at least double that size. And importantly, we had central quality assurance to ensure that the patients that were treated appropriately per protocol guidelines. And what we found was that hippocampal avoidance actually prevented cognitive toxicity. The relative risk reduction was 23%, or 1 minus the hazard ratio of 0.77. And what is really fascinating is that this risk reduction in cognitive toxicity was quite comparable to what we saw in Energy Oncology CC001, where we delivered hippocampal avoidant therapeutic whole brain radiotherapy for patients who had brain metastases. Importantly, we also found no difference or non-inferior intracranial relapse risk with those who received hippocampal avoidance versus those who did not. And we had similar non-neurocognitive toxicity. So the upshot of this phase 3 trial is that we essentially thought that we had broken the tie between the conflicting data from Europe. Better central quality assurance, double the sample size. And so the conclusion is that hippocampal avoidance should be considered for patients planning to receive prophylactic cranial radiation, very similar to the conclusions and the practice guidelines changes that were made when we stated that hippocampal avoidance should be considered for patients planning to receive therapeutic whole brain radiotherapy for brain metastases. But what is really a more important take-home point from our perspective is that now we've run 2 hippocampal avoidance trials in different disease contexts and in different therapeutic contexts. And in both situations, we see this play out. There's a cognitive protective benefit when you lower the dose per fraction and dose to the hippocampal dentate gyrus. So from that perspective, we are also concluding that the hippocampal neurostem cell compartment is in fact a radiosensitive structure at risk for all forms of brain-directed radiotherapy. And we as radiation oncologists need to be mindful of that. So now that we've reinvented the wheel of PCI, how do we use it? Well, does PCI actually cause meaningful cognitive toxicity? As mentioned before, there's limited evidence in small cell lung cancer. It's a bit confusing. Half of our small cell patients actually come in with impaired cognition prior to PCI, and there's a lot of confounding factors, smoking, the chemotherapy, paraneoplastic conditions. Does hippocampal avoidance provide sufficient cognitive toxicity mitigation to make the benefits outweigh the potential risks? Are we widening the therapeutic ratio of PCI? And importantly, as part of that therapeutic ratio, does PCI still provide a survival benefit in the modern era of MR surveillance and immunotherapy? And the only way to answer these questions, quite frankly, is in a randomized trial. So this trial is the Maverick trial. It's a phase 3 trial of MR surveillance alone versus MR surveillance with prophylactic cranial radiation for patients with small cell lung cancer. Patients are stratified by limited stage, immunotherapy, and performance status, and are randomized to PCI or hippocampal avoidant PCI versus MR surveillance. And it's a non-inferiority test for survival, and its sample size is large. It's about 600 patients. It was slow to accrue at first, but I believe in the past year it has really picked up, and it's roughly around 250 patients right now. And we encourage continued support of this trial because it really will help us understand the role of PCI moving forward in the modern era of small cell lung cancer. Okay, well, what about small cell lung cancer brain metastases? So now we get an MRI and we see gross macrometastases, at least 1 billion cells on those MRIs. And what do we do? Well, if patients have been treated with hippocampal avoidant PCI or PCI, the answer is pretty straightforward. We try to maximize radiosurgery, do multiple MET radiosurgery to try to avoid a second course of whole brain radiotherapy, where the cognitive toxicity of that is much more meaningful and much more debilitating for our patients. So that's pretty straightforward. But what about if patients have not had hippocampal avoidant PCI or PCI? And this is becoming an increasing number or proportion of our patients, and that's because of some of the data we discussed earlier that has questioned the survival benefit of prophylactic cranial radiation. So there's an emerging evidence of the use of stereotactic radiosurgery for small cell lung cancer brain metastases. Started with a number of retrospective studies. So there were retrospective studies across 28 studies that were brought together. And there was propensity scored match analyses. And this is an important study, but it's also important to recognize that it's retrospective and it took multiple centers who treat with radiosurgery predominantly and compared it to one center who had treated with whole brain radiotherapy. And they tried to compare the two. And so what they found is that whole brain radiotherapy, as expected, reduced the risk of CNS progression, but there was no overall survival benefit. Some people worry about leptomeningeal progression in small cell. It was roughly 11%. And some people worry about neurologic death or mortality, and it was roughly 12%. Further analyses essentially did the exact same retrospective study and then added to it and did a study level meta-analysis, but they're virtually the same patients. And again, reinforced that there's no overall survival between radiosurgery and whole brain radiotherapy. And then there was this important randomized trial called Encephalon from Europe. So this was a single institution study of about 56 patients who were randomized to radiosurgery versus conventional whole brain radiotherapy, meaning no hippocampal avoidance, no memantine for neuroprotective strategies, who had 1 to 10 small cell lung cancer brain metastases. And the primary endpoint was that memory domain, the Hopkins Verbal Learning Test, recall at 3 months. And what they observed was there was actually no statistical difference in the primary endpoint. But numerically, there is a difference in terms between 7% and 24%, which raised some question is conventional whole brain radiotherapy causing greater cognitive toxicity in these patients? There was no difference in overall survival. Limitations, small, single institution study, and importantly, did not incorporate what we would consider is modern whole brain radiotherapy, which is using hippocampal avoidance and memantine, which are considered standard of care in the US. So it leads us to this important study. This we see as a practice-defining trial for how to manage our small cell lung cancer brain metastases. Energy Oncology CC009. This is a phase 3 trial of stereotactic radiosurgery versus hippocampal avoidant whole brain radiotherapy for patients with brain metastases from small cell lung cancer. They're stratified by GPA or whether they've been exposed to neurocog testing, and they're randomized to radiosurgery versus hippocampal avoidant whole brain radiotherapy, 30 gray and 10 fractions. This trial had a sample, so the primary endpoint is time to cognitive failure, very similar to what we've done in all of our prior brain metastases trials, and the sample size is 200 patients. One thing that is not reflected on the slide is we actually amended the study last year. Now we're allowing any number of brain metastases patients, and we're stratifying by number of brain metastases. And importantly, after having done that about a year ago, our accrual has really kicked up quite a bit, and we're very grateful. We're now just past the 50% mark. We have 101 of 200 patients enrolled. We are anticipating that this study will close in the next couple of years, but we could use everybody's help to do so to try to get practice-defining outcomes to determine how we can treat our patients. One thing that's important to understand, though, as we're creating practice-changing, practice-defining outcomes from these trials is that not all brain mets are made the same. Not all brain metastasis patients are made the same. That there's clearly certain high-risk patients that perhaps may be a greater risk for neurocognitive toxicity than other patients. And how do we identify that? So we've launched a number of efforts using the approximately 1,000 patients that we've had on our 3 hippocampal avoidance trials within Energy Oncology to really understand this. So one is to look at ApoE4 genotyping. This is being led by Dr. Jeff Weffel, and he will be presenting results probably next year on what we've discovered thus far. We've been looking at baseline white matter integrity, the amount of T2 flare change at baseline in the periventricular white matter. This is being led by Dr. Joseph Bovi, who's done a phenomenal job shepherding this forward and has been a pioneer in this area of research and using a baseline MRI white matter integrity to understand cognitive effects of brain radiation, and then looking at the volume of the hippocampus and seeing if that is a risk factor as well. And the idea is as we really unfold all this and try to find a high-risk population, we then plan to take that to the results of our Energy Oncology CC009 trial and see if the same thing arises in the setting of radiosurgery as well. That's not something that has been evaluated before. But the goal is to find a high-risk patients to understand in which cases should we really, no matter how many brain metastases we see, we really should avoid whole brain radiotherapy and pursue a more limited radiosurgical approach. And who are those patients for whom hippocampal avoidant whole brain radiotherapy may have a magnified benefit relative to the overall patient population. So in conclusion, Energy CC003 has provided us level 1 evidence that hippocampal avoidance during PCI prevents cognitive toxicity. And what is fascinating is that the risk reduction benefit is very comparable to the setting of therapeutic whole brain radiotherapy for brain metastases, which really puts forward the basic conclusion, which is the hippocampal dentate gyrus is a radiosensitive cognition-specific organ at risk. This study does contribute to the evolving debate of the role of PCI in small cell lung cancer, for which we need level 1 evidence through the Maverick trial. And again, hippocampal avoidance is histology agnostic, and we need to understand its role in Energy CC001 for patients who have brain metastases relative to radiosurgery. I think I just made it within 30 minutes, and happy to be part of the panel. Thank you.
And I thank you so much. Incredible talk. You know, I think it's really cool to, you know, to be at a point, I think in both of our training actually, where we can see this transition and this story having been told that has absolutely just redefined how we manage all patients with brain metastases and the just how far we've come, right? I mean, whole brain radiation therapy and you know, used to be ubiquitous across all sites, and you know, the practice changing work that you and our team has propagated forward has made just a huge impact on people's lives. With that, we'll move into the panel discussion. So if all the panelists could rejoin us again, that would be great. Or if all the speakers could rejoin us again, that would be great. Jeff, I know I had asked this question, but I think it would be worthwhile for the rest of the group to hear, and I appreciate you replying in line within the chat box. But you know, these quality of life endpoints that we talk about are so critically important for these studies, and I know it's been somewhat of a struggle for the NCI to recognize the value of a non-survival endpoint in some of these trials. What do we need to do in order to continue to make sure that these quality of life endpoints continue to be incorporated into these critical trials that Vinay so eloquently discussed?
Yeah, thanks, Joe. Thanks for that question. I had left a couple of ideas in the chats. I'll mention those, and then maybe we can elaborate on those, and I'm happy to hear from others about their thoughts as well. I think a critical issue is that we have to, every time we propose a trial or ask for funding for some component of that trial, we have to be very, very clear about what is important about that. Why is this critical to the interpretation of the data? How is it going to impact our care for these patients? What's the relevance of this? And if we're not going for an overall survival difference, then this becomes even more important, because OS is obvious and everything else requires a well-articulated argument. And I think we've been pretty successful in doing that. Individuals like Vinay, Manesh, Paul, yourself, you know, are fierce advocates for this and have really helped to show in the context of radiation therapy where this makes a lot of sense. I think one of the challenges to our medical oncology colleagues is to integrate these outcomes into their studies. I think radiation oncology has embraced this and has demonstrated the value of this, but I think there are therapeutic differences and preferred neurotoxicity mitigation approaches to immunotherapies, to chemotherapies as well, and we simply don't see as much of that. The second issue that you know, is evident is that in centers with dedicated neuropsychologists and in investigator-initiated studies that have strong neuropsychology groups there, you will see, if you read these publications carefully, you will see less attrition in those studies. You'll see that we know how to interact with patients who are experiencing neurologic disease, neurologic progression, symptomatology. That's comfortable for us. We're familiar with that. We work with brain tumor patients every day. I think one of the challenges in cooperative group studies or multi-site studies where they do not have neuropsychology staff present that are doing this, but we're training healthcare workers to be able to deliver these tests and collect this data, is that there is a tendency for patient when they see patients to worsen neurologically, which is the expected course, to kind of give up on collecting this data. And that oftentimes is leading to higher rates of attrition and gaps in our ability to analyze this data over time. I think we need to increase our rigor in collecting this data, just like we do the imaging studies. I promise you, none of our patients love laying in the scanner for an hour. I promise you that. Everybody thinks that's really easy, no problem. We spend less time talking to them than they spend laying there worrying about the results of that scan. And yet we have much better compliance with the imaging studies. So, I really want to emphasize that this is feasible. We just need to change our mindset toward this. And if we do that, that takes away, I think, another one of the issues that our funders have, which is, are we really able to get this from patients? Can we keep them engaged? Can we collect this data? Is it worth the money that we're putting forward to do that? So those, I think, are two kind of premium issues that lead to increased enthusiasm from NCI.
Eloquent answer. Thank you so much. I appreciate that. There was one question in the chat for Dr. Shmenda, and one that I've been curious about as well, just with having had the opportunity to work with you with these FTB maps and helping make clinical decisions in patients with regard to progression versus necrosis, which is always a hotbed topic in any previously treated brain met. But the question that was asked by one of the attendees, what FTB would be considered calling true tumor versus necrosis that would necessitate the need for people like Max to consider a biopsy and perhaps lit on the backside of that?
Great, thanks for the question, Joe. Yeah, sometimes it's not clear because all the treated tumors typically are some admixture of tumor and treatment effect. I think what this helps is, especially in the cases of pseudoprogression where the majority of the tumor, it looks like it's definitely enhancing, the enhancement's increasing, and you look at the FTB and it's predominantly blue, right? So I think that lends confidence for just maintaining the treatment course. When there's an admixture of tumor, I think this is where we have to get FTB into the hands of a lot more clinicians so you can kind of beat it up and say, okay, where does this really help me in making those management decisions? But what also is coming down the pike, in fact, just recently opened, is the EAF 223 trial. It's the ECOG-ACRIN trial, and it focuses, the center of that trial is actually using FTBs in the setting of, distinguishing progression from pseudoprogression. So it's exciting to see this underway in a clinical trial setting to sort of really come up with those answers also, and in comparison to other potential imaging biomarkers. So it's in the works. So yeah, we need everyone's input on it also.
Love that.
Yeah, I would just briefly add to Dr. Schmeida's point. So having the FTB maps to use as targeting for stereotactic biopsies has been a game changer in our practice, because there's this very well-known and well-described phenomenon of heterogeny in these recurrent mets that a lot of, part of it is radionecrosis and part of it is tumor. And the only reason that's a problem is because it makes stereotactic biopsies inaccurate. And there's a well-known phenomenon of undersampling. So if you really need a good sample, at least for now, you have to do an open craniotomy and resection and target the whole thing. But the difference for a patient between an open craniotomy and a stereotactic biopsy, which nowadays we're doing through a stab incision and oftentimes under just MAC, not even general anesthesia, is a big difference. So being able to target the biopsy to a high yield area basically takes away the problem of heterogeny and stereotactic biopsy undersampling. So far in our experience is relatively young, but we've been doing it maybe for a year now. And there are several cases where you get this sort of ring enhancing lesion and half of it is blue and the other half is yellow or red. And along the same trajectory, I'll sample the blue part and I'll sample the yellow and the red part. And it's been highly, highly accurate. So I think now what we're working on is sort of defining the thresholds for because there can be little speckles of one color here or there, and sort of how much is likely to be positive is really huge. But it's definitely increased my confidence in the appropriate target sampling for these otherwise heterogeneous lesions.
Thanks, Max. I think that clinical description of how you guys are using that at the college is really, really helpful. Dr. Glitz, I know you also replied in line, but there's a recently published article that had highlighted the benefit of perhaps treating metastatic melanoma and actually multiple pathologies that happen to be 1 centimeter size and greater with stereotactic radiosurgery first prior to introducing targeted or immunotherapies. And I think all of us have seen practice-changing results where we'll see small volume disease in patients with EGFR, ALK mutated non-small cell lung cancer, or even BRAF mutated melanomas, and just pause and not do any radiation and just let them move on to those systemic therapies as an effort to control. But what are your thoughts on that recently published work showing that perhaps that larger volume of disease would necessitate the helping hand of a stereotactic radiosurgical treatment prior to targeted treatment?
I think it's a great question, and I'm not sure I have the answer. I think I put in the chat that, again, in low volume, asymptomatic, I think we feel very safe and comfortable to go in with systemic therapy up front. I think one important aspect is that we do check early, right? So in the study CheckMate 204, the time to response was just 1.6 months, which maps out to the 6 weeks after 2 weeks of ipi-nivo, right? So we do what I would call early look. So I think this is an initial safety build-in. But I think one thing that I maybe failed a little bit to highlight in the studies, as exciting as they are, is what you're actually talking about. How about if the volume is not just 1 or 2 brain mets, but maybe 4 or 5, and they're a little bit bigger? These patients were not as strongly represented in the trial, right? So the trial had smaller lesions in general, smaller numbers. But I have to tell you, we've all seen wonderful results, even in patients with 30, 40 brain mets that really melted away. And again, we all love to have randomized brain mets trials. I'm not sure if they will happen ever or anytime soon. But I think given that we also have a very active brain metastases clinic at MD Anderson, where pretty much all patients that go on trial or are eligible for trial are being discussed, I have to tell you, our radiation oncologists have not pushed back yet based on the paper and said, let's watch, but always with a close standby option. So we have not really changed our practice based on this. And again, I would argue it's a great paper, but it's still just one paper, and we do need randomized trials. So, and this is why I said we typically start, and again, we typically never start BRAF/MEK. But what we do very commonly is what I also described is if we do see some changes or some progression in some lesions, we really go ahead and just treat with SRS right there and just add it on. And I think this is, again, something we need to allow in trials in general as well.
Perfect.
And just a follow up to that, Dr. Glitz, since LMD is one of your passion, there is some data that's coming up with this nodular LMD after SRS. Can you comment a little bit about that entity and do you treat it any differently?
Yeah, so this is what I'm kind of, you see, I'm making a face and maybe even rubbing my face and can't hide my frustration in general. So I think, let me go back. So I'm going to be very honest. So I love my radiology colleagues, but it's been driving me nuts for the last 10 years that we always stick to a definition of LMD if it's this classical linear enhancement. So, I mean, this is one thing where I'm like, I think we need to get away from what's classic and what we've seen develop over the last decades, because we've seen so many patients, you all have, that have, again, mainly often a BRAF mutation, and they have this miliary rice corn distribution. And no, it does not look like classical LMD, but in every grove, regardless of what cut you do, you have a little dot sitting. And sure enough, we do the CSF and it's positive, right? So I think, number one, we as a community need to push and really reevaluate. Then there's this question about this flip, right? It's right under the surface, but it's this thickening lining. So I think we're realizing that, again, as parenchymal brain metastases come in different flavors and probably have also, to a degree, different prognostic outcomes in regards to development of LMD, right? The ones that are just plugged under the dura versus the ones that are just kind of hanging in the middle of the parenchyma with nowhere close to any, CSF access. So sorry, I'm getting a little bit tracked away. But so I think, again, to focusing on nodular LMD versus linear LMD, I think it puts us into a wrong direction. I think we need to be more aware of CSF dissemination as a whole. I think we need to look very closely at the diagnosis and do better, probably not just radiographically, but with RNA, with cell-free DNA, or with tumor cells with cell search, right? So I think we need to really make this more standard to identify these patients. And then again, to focus on one versus the other, I don't know what to say.
I think I would 100% agree. And I think Max, like people who operate would also agree. There are times when I'm like convinced that it is in the LMD space along with having a parenchymal component. But many times we don't do, lumbar puncture. We don't really do cytology. We just call it as another parenchymal met. So I think like bringing attention to that. I think that's adding to this like low overall survival because it's just getting underdiagnosed or under radar.
And I understand, right? If you have somebody that has 50 or 100 of these new, I'm going to call them miliary little spots that are all, again, right in the sulci, does it really matter if I call it LMD or not, right? I need to treat. But I do think as a field, we need to move away from maybe some of our classic definitions and really understand that also the diseases to a degree and how they present have evolved based on the therapies that we're using, right? I think we do see different presentations even within the CNS based on the drugs that we're using. And maybe one comment back though to the TKIs also in lung cancer. I think again the factor is that immunotherapy is just such a different type of treatment with again the potential of durability compared to BRAF/MEK or EGFR inhibitors or anything. But again, I think with immunotherapy and melanoma, the upfront immunotherapy approach is still appropriate in a good number of patients, just as another thought to coming back to that.
And I guess just staying in line with the surgery theme for Vinay, since you are moving from PCI to SRS for non-small or for small cell, so where do surgeons fit in there? Or do we?
Surgeons
You always fit in. Yes.
Yeah.
We love surgeons.
Surgeons are the key component to the team. I'm glad that Dr. Glitz and I said the same thing at the same time. Great minds think alike.
And even if an Omaya doesn't seem to be spectacular, but you're making, the next steps in treatment possible for my patients. So we love our surgeons.
So let me address Dr. Glitz, the question Dr. Glitz had the last one, and then add that onto here. So what are we dealing with? So Joe talked about how we used to treat everybody with whole brain radiotherapy, right? Even after surgery, we used to treat with whole brain radiotherapy, and we never saw this kind of LMD then, right? We didn't. But now we're more focal and we're seeing a lot more LMD. Why? Patients are living longer. And two, we're not treating the whole brain for understandable reasons. When we were treating the whole brain, we were treating the intracranial CSF compartment perhaps before it started circulating. And now we're not. So our threshold and our sensitivity has to rise. It has to get better. I'm as passionate about as Dr. Klitza because I see a ton of LMD at Northwestern at the Proton Center. We have to do better. It's what I tell my patients is suddenly when you have any suggestion of LMD, you suddenly open up a third front in the war against your cancer. It's not just systemic, it's not just the brain, parenchymal. It is now the fluid that's circulating, and we need to do better. And the surgeons are so important to this because, in my experience, patients who have true LMD, the most likely cause of their passing, fortunate passing, is communicating hydrocephalus. And it is so important, and it took us a long time here in Northwestern to convince our neurosurgeons, put that shunt in, or put that, do something to help us manage these cells that are multiplying very quickly and clogging up an arachnoid villi and creating communicating hydro. But at the same time, do the VP shunt with an Ommaya so we can start putting stuff in there. And let's be proactive and not just diagnosing it, detecting it, managing it, and preventing what might impact that third front that we're battling. So, so to your questions, Mahua, SRS focal therapy has a role. We are really interested in proton CSI or intrathecal rhenium as new approaches to managing LMD. But it's very much a team-based effort, and everybody's got to buy into how important it is. We can't toss in the towel on these patients. How important it is to manage the LMD to help their survivorship and quality of life.
Dr. Gandhi, can you talk a little bit about your decision making for when, if somebody presents with an initial brain metastasis, it's either resected or biopsied, and it comes back as small cell. How do you decide whether to do whole brain or focused radiation up front?
Yeah, Dr. Krukoff, it's a great question, and I don't have a good answer. I enroll patients on CC009. That is what we do here, is we really try to put patients. Now, I did have a patient recently who had non-communicate, who had communicating hydro, normal pressure hydrocephalus at baseline, has nothing to do with LMD. And I couldn't put her on study because she is not eligible. But she has limited disease. And so in that scenario, I think about SRS, recognizing that the strategy of hippocampal avoidant whole brain radiotherapy is a card that I will likely play in her survivorship at some point, but I can only play it once. Do I want to do it when she's got 1 or 2 brain mets, or do I want to do it when she comes in with 15 or 20 brain mets? Because I think one thing that we underestimate is not well reported in our trials and literature of radiosurgery is the risk of RN. And we know that what drives the risk of RN, radiation necrosis, is volume, number of brain mets that get treated in one session. That is an important thing. And so we talk about cognitive toxicity, but we're essentially trading one toxicity for another in that situation. So when I play that card, I'm thinking, okay, what is a toxicity? Well, if I SRS 2 brain mets, the likelihood of radiation necrosis is extremely low. Even if I use hippocampal avoidance and memantine, there's some cognitive risk. Okay, so let's try SRS off trial. But in the setting of someone coming with 15, 20 brain mets, if I try to radiosurgery all those, there's a very meaningful risk, even if I fractionate, of causing radiation necrosis. But if I can control their disease, I might be actually able to help their cognitive function overall. And that's a situation I would consider hippocampal avoidant whole brain. Play that card at that moment and then monitor them. And if something shrinks and then grows again, then we can radiosurgerize it. That's just my personal bias and approach, but I think it's something that we keep debating and we need modern trials for.
Yeah, no, thank you. I'm really interested in the case of like 1 or 2, the focal ones, because and it sounds like now your practice, off trial practice is to start with SRS, which I think is really interesting.
And that's simply because they'll probably come back to me 6 months from now with 15 brain mets. We know that's going to happen, and I'd like to play that card then.
And for Dr. Weefel and also for Dr. Gandhi, when we are reporting these trials, are we now also including like sex as an independent variable and maybe like more granular age stratification as independent variable, because cognitive function declines with like hippocampal size declines with aging. There's like hippocampal function declines with aging. So is there more of a concerted effort to take those like natural decline or like natural dimorphism into account?
Yeah, Mama, that's an excellent point. Most neuropsychological tests are adjusted for age when we characterize the performance of a given individual, right? We don't expect the same test performance out of an 80-year-old as an 18-year-old. So that's already factored into a portion of the analysis. And most of the time when we're doing linear modeling, we are including age as a covariate. I think sex as a independent variable or as a factor in our analyses has been less well studied. And I agree with you that I think that there's a great opportunity for that. It's not something, there's one of the test on the clinical trial battery, we adjust for sex on that because we know that it makes a difference in terms of verbal fluency. But for the other tests, it's not been demonstrated to be strongly associated with cognitive performance at the normative level. But we're not looking at the interaction between sex and many of these treatment outcomes, which I think is an opportunity for us.
And let me add to that. First, I smirked at Dr. Glitz's comment that she got so excited about LMD she knocked off her camera. That's pretty funny. So there's no question, no matter what trial we do about brain-directed radiotherapy, age always impacts cognition. I think Jeff would agree, and it just keeps repeating itself over and over and over again. And I think our ability to understand age has been limited to simply chronologic age. But there's more to age than simply how many years we live, right? We all know that. And so our attempts right now are led by Joe and others is to use MR imaging as a way to define age. And we're doing a number of translational research studies right now to look at we got thousands of patients on these hippocampal avoidance trials. Look at that. Can we understand age based on the MRI, based on not just T2 flare abnormalities, but even parenchymal brain shrinkage or cortical thinning, to be able to predict more accurately than simply chronologic age as to the likelihood of cognitive toxicity, and more is to come with that.
I might have to jump off because I am getting paged, but maybe one thing I wanted to highlight too is, again, thank you very much to my radiation oncology colleagues that have gotten also more willing to consider focal radiation for focal LMD, right? So I think we all have seen, again, patients that don't have this widespread disseminated LMD pattern, but have focal enhancement in maybe 2 or 3 spots. And I think there's now at least some retrospective data and publications that show that these patients can be, again, how do we define success, but at least temporarily stabilized with SRS. And I think, again, this shows that as we're learning, our practices change dramatically from upfront recommending whole brain in anybody who has suspicion for LMD, where we now go in and again offer systemic or intrathecal treatments where we use SRS. And again, some of these patients have lived for a long time. When you saw my presentation, I did have a picture of I call it the LMD for the blind for my residents, right? I mean, it's just so there, you cannot miss it. But, this patient, again, I think you all saw this picture. She's been alive for 2.5 years. I cannot explain why this woman and how this woman was alive with 2.5 years. We gave her intrathecal Nivo for over a year. She was on concurrent targeted therapy, but to be again, what differentiates like one patient who has barely anything visible to others that live with this incredible LMD disease burden and are highly functional, we also don't know. And so, again, I think the multidisciplinary care for these patients, as everybody who's currently on the panel has stressed, should never be underestimated, including cognitive function and quality of life and all these things that we sometimes overlook in our quest to just treat. But again, I have to dial off. I'm so sorry.
And while you dial off, I'm going to add to what you said, Dr. Glitz, because I couldn't agree with you more. People always ask, hey, would you ever use hippocampal avoidant or whole brain radiotherapy for LMD? And the answer in my mind is no. You need to have the ability to treat with proton CSI if you have a proton machine close by. And when you do whole brain radiotherapy, you knock that off the table. I've seen so many consults come to me, they get whole brain radiotherapy, and 4 months later, they got diffuse spinal LMD, and it's too late. I can't treat that at that point, as Dr. Glitza knows. Yep. So yes, I agree with Dr. Glitza. Focally radiate, manage macro disease, try some IT therapies that might be effective, have a proton CSI plan ready in case it doesn't work, but don't burn a bridge on something that we know works.
Thank you, Dr. Glitza. I know you have to step off and get back to being on call, but we thank you so much for your attendance today and a brilliant talk, and your commentary was fantastic. So
I think one more question just popped up for Dr. Gandhi that says, at what threshold of disease burden should you pick for proton CSI?
Yeah, so it's a really good question. I don't have a really good answer. So the data that we have, so we have BN14 opening soon. If you guys have a proton center, I know UW will have one and MCW will have one. So we're excited that you guys will be able to join the proton community. And this will help answer a lot of those questions, because now we have a limited phase 2 from Sloan, and we have like limited experiences. We have a lot of it here at Northwestern. But my perspective on it is if there is a really effective IT therapy, like Dr. Glitza mentioned, or other systemic therapy that has the ability to control that CSF disease, I'm holding off so long as they're asymptomatic. Unless I see diffuse disease going down the spinal cord or around the spinal cord, then we have to do something because that's not worth messing around with. And if we have gross disease in the brain, we'll just cherry pick lesions to treat because we know IT doesn't work as well for gross macromets, although some of the immunotherapy approaches may do better. But we always know that no matter what intervention we use, the less disease we have in the CSF, the more durable our control is going to be. So in my experience, when I've treated patients with diffuse LMD, I'll get them to 9 months or 10 months of control, and then they start growing again because of how much disease they have. If I have microscopic disease, I can get them much longer out with proton CSI. So one of the things we need to think about is if proton CSI shows in BN14 to be a survival benefit and changes practice, how do we add to it? How do we augment the PFS benefit by adding ITs, by adding intrathecal rhenium, to doing something else that creates more durable progression-free survival? And I think that remains to be determined.
Perfect. We are about at time for our morning session. I want to thank all of our speakers this morning. These talks were just amazing, and I always love the conversation of our panelists at the end. Dr. Gandhi, Dr. Shmainda, Dr. Glitza, Dr. Wayful, thank you so much. We're going to take a pause in our presentation for the morning and resume our talk at 10:30. So everyone can grab some more coffee and take a bio break, and we'll see you back at 10:30. See Dr. Luthard on now. Eric, welcome.
Hi, how are you?
Phenomenal. What do you think, Dr. Day? Should we get going here?
Yeah, I think it's about 10:31, so I think we can convene the late morning session. So I will let Dr. Krakow start with the introduction.
All right, welcome back, everybody. It's my distinct pleasure to introduce Dr. Luthard. Dr. Luthard is a neurosurgeon. He's currently a professor in the Department of Neurological Surgery, Neuroscience, Biomedical Engineering, Mechanical Engineering, and Material Science at WashU, St. Louis. He's also vice chair and chief of their division of neurotechnology. Dr. Luthard is an internationally renowned neurosurgeon, scientist, and innovator. He's created and translated numerous high-impact medical innovations. The list goes on, but notably, and for today's conference, Dr. Luthard has been one of the pioneers and foremost neurosurgeons pushing forward the use of LIT, laser interstitial thermal therapy. It's one of the reasons we've invited him to talk to us today. Last year we had Peter Fecci kind of give our group an introduction, and Peter Fecci and Eric Luthard are on pretty much all the high volume data papers for LIT. So it's my real pleasure to introduce Eric and hear what he's got to say.
Well, Dr. Krukoff, thank you very much for the kind introduction. It's a pleasure to be here and tell you about something that I've been passionate about for the last 15 years, and making laser kind of a much more really a pinnacle or a pillar of kind of how we take care of patients. And I'm just going to share my screen. Oops, let's see. Got to grant access. Sorry about that. Let's see here. Okay. Okay. Let's try that again. I've got to, for the Cisco, I've got to give permissions. I gave permission.
You might have to leave the meeting and come back for it.
I see. Okay. I really apologize. Give me just one moment. I'm going to leave and come back. I'm sorry for that.
No worries at all. That's fine, Eric. Yep.
Okay.
It's all good. We'll see you in just a second.
Okay. Thank you. Okay. Back in a moment.
All right. That was fast. You're back in and we can see your screen. So that's perfect.
Oh, but now he's muted, I think. Can we unmute him?
Oh, yeah.
Okay. Okay. All
All
systems
right.
go.
2
Hopefully you
for
can see
2.
me.
Vision,
You're all-
vision and auditory.
Okay, great. Again, thank you for your patience. So again, what I'm going to talk about is laser interstitial thermal therapy, LIT, and why I think in many ways this is a sea change for the treatment of brain tumors. Certainly, we're going to talk to a degree metastases, but just generally, that this is a way that we can really enhance the outcomes of our patients. So again, disclosures, I'd say the most relevant is, occasionally I do some consulting for Monteris Medical, but the remaining are not relevant to this talk. And, where I think when we really started thinking about LIT was this idea of difficult to access tumors that, how do there's certain tumors that we can't go after through classic open surgical means. And, deep tumors in the thalamus, tumors in the insula, and that they carry some morbidity that can potentially be prohibitive. And so when we think about neurosurgery more generally, we're always trying to kind of balance this idea of cytoreduction versus functional preservation to give patients the best outcome. And that's where I think, again, we talk about LIT. Another phrase you'll hear is stereotactic laser ablation. That I think that this approach really strikes a new balance that gives us new ways of thinking about how we can treat brain tumors. Again, it's minimally invasive. Importantly, it's MRI guided, meaning you get real-time feedback and you get real-time thermal damage monitoring. So you can really precisely see the lesion that you're creating in real time. And really just to kind of, give a video of this to kind of give you some insights of kind of what this entails is that, again, the small incision, several millimeters, a bolt is placed in the skull, and then we insert a laser probe into the tumor and we get real-time MRI imaging of where it is, but also the thermal damage that we're creating with it. And so again, just, the surgeon is actually outside the MRI scanner. We're at the kind of the screen that controls it, and we literally control this MRI compatible robot to move it backwards and forwards. We can use directional lasers to kind of change the shape of the ablation, so it really can create a conformal lesion. And once we're done, we take that bolt out, and usually can close that incision with 1 or 2 stitches. Now, the way that the laser impacts the brain varies depending on how much kind of heat it gets. Again, there's what we call the necrotic core, where it's greater than 46 degrees Celsius. There's sublethal damage when you're at 41 to 45, or just physiologic hypothermia, 38 to 41. I mean, I think when I first started doing this, what's pretty amazing is that it's not that much different in terms of the temperatures between what is kind of physiologic fevers to what actually creates real and lasting damage. And so again, the zone 1, it really is kind of irreversible cell death. Zone 2 is reversible cell damage and breakdown of the blood-brain barrier. And then again, zone 3 is inflammatory changes or fever range. Again, I highlighted this already, but again, what I think I get so excited about this is that this is a very small surgical footprint. We put that bolt in, and then after we've done all this, it's a very small kind of incision. It's very hair sparing. We don't have to shave much hair, and exceedingly rarely do we ever have any kind of wound complications. Now, where we started when we think about this is, again, as I said, these difficult to access tumors or recurrent gliomas. But really, the application has really expanded to, whether it's, again, difficult to access tumors in the posterior fossa, multiple lesions. I think that this is very important in consideration for metastases, is that tumors that have recurred after stereotactic radiation or even just radiation necrosis itself, I've found those patients to be have benefited greatly from this laser approach. And I'm going to just skip over that. And there's a whole host of ways that you can use this for epilepsy, but I'll kind of leave that for the moment. And I'm going to talk a little bit how we've used it at Washington University and how that scales in our national experience, and kind of some takeaways. Now, when we first started doing this, in the first, I'd say, 5 to 7 years, kind of, what did we treat? Again, it was gliomas, metastasis, radiation necrosis, as well as, some, kind of, more one-off type of stuff. I would say kind of as far as kind of your early learnings, first and foremost, it's there's a lot of technical steps to these cases, even though it's minimally invasive. And I think one of the things that's really important is that the efficiency, really goes down the more you do. Nowadays, we can do 2 to 3 cases per day. But in the first, when we were first starting doing this, it was taking us up to, 5, 6 hours. But I think that's the evolution of the technique as well as the evolution of the technology. And again, that's the same for kind of how long patients stay in the hospital. Early on, they would stay for longer periods. Now, the vast majority are discharged the next day. I'd say the other thing, as far as kind of early learnings from this, is that tumor volume matters. And again, these aren't strict prohibitions, but what we found is once you got to kind of a volume roughly comparable to kind of a 3 centimeter maximum diameter, you started to see more complications, whether it's swelling, seizures, electrolyte abnormalities. That there's something about once you get to that larger size that the inflammatory effect by the laser starts to you start to see the patient tolerate it less. Again, not a strict prohibition, but it's something to be aware of. So again, when we think about neuro-oncology, again, I think some of this is repetitive, but worth saying again and again, is that again, new and recurrent glioblastoma, refractory brain metastasis. Again, we've had multiple experiences with this. Patients do really well with this, but I think there's some caveats. Radiation necrosis, inoperable tumors, meningiomas. And I think importantly, one of the things I'm going to highlight at the end is the ability to do novel trial protocols. So again, some early examples. Again, where we started was tumors that I cannot take out with open surgery or would be really reticent. Thalamic glioblastomas. Again, this is just an example after 1 year. Again, the patient went home the next day. These patients, again, relative to surgery, that these patients do really well. And again, we validated that, and this is in collaboration with the group at Cleveland Clinic. One of the things we highlight is like, well, again, how does this compare to standard, biopsies? And one of the things that we found is that we can classify patients into favorable, intermediate, or unfavorable. And I think one of the key things is that you've got to treat a sufficient volume of these tumors. Some of that sounds kind of obvious, but it's really important to highlight. Again, just to show you an example of a deep-seated tumor that we treated, several years ago. Again, this is an insular GBM. Again, the patient initially presented with some, distorted speech. Again, we did functional imaging. We mapped out both the arcuate fasciculus, the corticospinal tract, as well as the resting state networks involved with, language and motor. And just to kind of show you this one in particular with the insula. Oops. Got a pause there. Let's see if I can try that again. Again, I'm just going to show you the tumor itself in 3D rendering. And there you can see it relative to the middle cerebral artery. There it is relative to the arcuate fasciculus and the corticospinal tract. And for this, we took a parietal approach, which avoided most of those tracks, so that we did 2 probe trajectory into that insular tumor. And we were able to treat, again, greater than 90% of the volume of that tumor. Again, here's what it looked like post-operatively. And the patient, speech was maybe a little bit diminished after surgery, but basically, it responded by about a week, was back to normal. And here's what it looks like, 1 year later. So again, I think that was a really satisfying case. Again, recurrent glioblastoma. Again, that's a workhorse for a lot of the cases that we do. Again, you've got a foconodular region, and again, these patients do exceptionally well, both after surgery, but also from a outcome standpoint. Again, just another example. Again, this was a glioblastoma that was resected, and then it basically as glioblastomas do, it presented with a focal recurrence. This one, we combined lit plus pembrolizumab, and basically, again, ablated that lesion, without difficulty. And this is what it looks like 2 months post-op. And so again, we've had, a multitude of these experiences, and we've also, I'm the PI on what's called the Lantern trial, which was a prospective clinical trial to basically look at all comers of patients who were treated with lit. This is kind of a RDH1 wild type cohort. And basically what we see is we treated both lit for kind of, either new tumors or recurrence. And I think one of the things that, when we think about adverse events, the adverse events are quite low. Again, it's 13.5%, but are transient and related to edema. And I think that's the one thing I'd highlight, is that the vast majority of patients really do well after this. And importantly, their survival is pretty good too. Again, for newly diagnosed glioblastomas, the overall survival is 16.1 months. Again, that's comparable to kind of open surgery resection plus radiation and chemotherapy. And when we look at recurrence, that again, when we laser patients with recurrent GBM, that we're seeing around 9.1 months of survival, and that's again comparable to a lot of the findings that we're seeing with kind of the studies that we're seeing with laser. Now, again, I'd say that's kind of the lead up. Like, we're obviously here to talk about metastases, but I think the thing that I want to highlight is that that really this is becoming a ubiquitous tool for kind of dealing with lesions in the brain. And so kind of metastasis, interestingly, the first tumor that we treated with lit at WashU, which was the first FDA-approved case, was essentially a metastasis that was refractory to gamma knife. And what we're finding is that in our initial WashU experience, that we were, getting a response to these. Median overall survival of these patients, was around 13 months. But again, when we first started doing this, that progression-free survival for that met was around 6.3 months. And some of the early learnings of this was that what's different from glioblastoma, where you treat the volume and you get this, cytoreduction, metastases are slightly different. What I mean by that is they are actually, relatively well separated. They're almost kind of like, I almost describe them as like little hot dogs in the brain. And when you heat them, they actually expand compared to glioblastomas or gliomas, where you're just heating through the tissue. And so one of the things that we really learned from this early experience is that you really have to heat beyond the margin of the tumor to get effective control. And so the other thing that we learned is that this is really great for treating radiation necrosis. And again, for radiation necrosis, that we really got robust. Oops, excuse me. Oh. Sorry. That we were able to show in a statistically meaningful way across 90 subjects that we could really facilitate a more rapid cessation of corticosteroids, so that patients really didn't have kind of that longer term, adverse sequelae from taking steroids. And so that's also been quite satisfying. So we really, when we see radiation necrosis, we are much more likely to pull the trigger on doing earlier lit to get these patients off steroids, which I think overall serves them pretty well, especially given the low level of morbidity with the surgery. Let's see here. Oops. And I think this is, kind of another thing that I want to highlight, and this is a lot of work that's being done by Peter Fecci out of Duke, and we've been collaborating, is that, when we think about recurrent metastases after SRS, there's been an active question is, should we do lit alone? Should we do, SRS alone again? And it appears that doing SRS plus lit gives us the best median overall survival for these patients, as well as kind of really substantially extends that local progression-free survival. So I think that, doing lit plus SRS for these recurrent metastases really is giving us a meaningful benefit. So, and again, I think I'm going to kind of go through some of this quickly. This WashU experience, these more local experience has been recapitulated by our Lantern registry, where again, we're seeing this at much higher numbers. And again, this is we've published numerous papers around this. But again, similar to kind of again the total experience of what people are using is again recurrent Mets, recurrent high-grade gliomas. New high-grade gliomas tend to be the workhorses for kind of how you're using laser. But again, you see Mets becoming more and more common. Oops, my goodness, I got a hair trigger today. I think one of the things as we look, across multitude of centers, hundreds of patients, the one thing I want to highlight here is, again, as we think about just the global care of these patients, when patients with brain tumors are being treated by laser, that their overall quality of life regarding this procedure, their mobility, their self-care, their ability for usual activities improves. There's no clinical changes in pain, discomfort, anxiety, or a visual analog scale. So the quality of life for these patients getting laser is quite good. And overall, when you look at, again, formal metrics, the FACT, FACT-BR, the brain tumor specific, measurement of quality of life, their emotional well-being is improved with this therapeutic intervention. And I think that's just important. Not just are we controlling disease, not just are we, showing, radiographic improvements, but the quality of life of these patients is getting better. Again, I think that, again, to beat a dead horse, again, the hospital stay is short, the safety is high, the readmission rate is quite low at 1.8%. And again, this is just all comers for all, again, across much larger cohort of patients across the country, whether it's metastatic, primary, new, that, again, the overall survival probability, especially with some of those early learnings, is really quite good. And I think, one of the things I want to highlight is we're also, now that we're getting this, robust experience in that, there's surgeons doing both open and laser, how do these things match up? Because I think it's a common question. It's like, is it better to take it out? Is it not better? Like, and so we're starting to look at that as well. And one of the things we focused on where I think there still remains some equipoise of whether you should take it out or whether you should ablate it, are tumors in the insula, specifically insular gliomas. But I use this really as a kind of a platform to really think about how laser, when you compare it to open surgery, we should think about it. So again, for these, we looked at a cohort of patients, a total of 24 consecutive insular gliomas. Half underwent resection, half underwent laser. I'd say that kind of the key differences, when we think about this cohort, is that the open resected tumors were slightly larger in volume. But I think, again, just things that, again, are probably not that surprising when we look at the difference between ICU stay, hospital stay. Again, patients with laser, very statistically significant difference in kind of how long patients stay in the hospital. The likelihood for discharge to home trended towards, lit versus open was better. Certainly, there was a big difference in postoperative deficits. That was statistically significant. And obviously, there's a huge difference in estimated blood loss. But I think, for me, one of the take homes here is that for these, difficult to resect tumors, I think sometimes in our mind we justify, well, maybe this is giving them a better outcome in the long run. And we looked at that. And when we look at progression-free survival, again, open is in red, lasers in blue. The thing that I'm not trying to say one is better than the other, but the thing I can say is that these, Kaplan-Meier curves are not statistically different. And so that I think that overall outcomes for these patients is about the same. And I think that really kind of tells us that laser is accomplishing the same level of cytoreduction at a reduced morbidity for a shorter length of stay. And that I think we should really use laser to kind of treat, really, again, as I said in the beginning, it should really be a pillar of how we should think about intervening with kind of tumors, especially tumors less than 3 centimeters in size. And I think finally, let me finish up by saying that I think LIT really enables novel clinical trials. And what do I mean by that? Is that in addition to the cytoreduction that I've been talking about for the last 20, 25 minutes, is that it really does break down the blood-brain barrier. And we first published this back in, I think, 2016 or so, and showed that basically when through both, blood-based metrics as well as imaging metrics, that the blood-brain barrier essentially remains open for 4 to 6 weeks after you've done the ablation. So it's at that periphery. So basically, you've got your tumor, you've got this new enhancing margin around the area that you've ablated, and that remains. And whether it's kind of blood flow metrics or kind of serum measurements of breakdown of the blood-brain barrier, that remains open for around 4 to 6 weeks. And I think what's really interesting about this, and this is work that I want to highlight, Albert Kim, one of my colleagues, did in mouse models, is it's not just that you've damaged the endothelium, but you've actually altered tight junctions, but you've also enhanced endothelial-transcytosis. So there's something about that heat that changes the fundamental characteristics of the endothelium, so that's more likely to kind of, not just passively let things egress, but actually, enhances transcytosis, which I think is a really neat and cool finding. So we've done a couple clinical trials where we've basically combined this with drugs to see about the impact, specifically doxorubicin, which historically has been understood not to penetrate the blood-brain barrier. But again, in this particular example for glioblastoma, we show that when you combine doxorubicin with LIT, that actually for recurrent glioblastoma, that does make a significant difference in progression-free survival and overall survival. So really kind of, to finish up, I think laser is playing a larger role in the management of brain tumors. Key diagnoses include, difficult to access gliomas, recurrent gliomas, and metastases post-radiation. And then I think that this really creates a novel opportunity to give agents to the brain that otherwise would not access the central nervous system. So again, I think I'm at the end of time, and I'm on time, which is kind of shocking, and I'd be happy to take any questions.
Thank you. That was a great talk, and I'm hoping that you can stay till the end of this session for the panel discussion, because that's where we're like leaving all the questions for.
Okay, great. Yep.
But that was a great talk, and that leads us to, I think, our next presenter. It's a very good follow-up, and it's my pleasure to introduce our next speaker, Dr. Alireza Mansouri. Dr. Mansouri is an assistant professor of neurosurgery at Penn State, and he's an expert clinical trialist, and he leads the Big Ten CRC neuro-oncology trial group. And his research interest lies in developing next-gen therapeutics for brain cancer, and is doing some of the very exciting work in the field of liquid biopsy. And today he'll be discussing CSF proteomics for optimization of brain metastasis management.
Well, thank you very much for the very kind introduction, and thanks for inviting me to present our research. I'm just going to share the screen. Okay, do you see my screen? Yes?
Yes, we can. Yes.
Okay, all right. Perfect. Thanks again for the committee for inviting me. It has been a very informative morning and very diverse, multidisciplinary series of discussions, and it's actually set the stage well for my talk. So I will be talking about optimizing the management of brain metastases with CSF liquid biopsy. And to accomplish this, first we'll talk about CSF. We have talked about this so far today, how CSF can act as a CSF sanctuary, but I also want to present some evidence and some food for thought that perhaps CSF can be a nidus of entry for extracranial cancer into the central nervous system. And then I'll give an overview of the state of CSF liquid biopsy in the literature, and then talk about some of the work we've been doing with low input proteomics, and then finally bring this all together to discuss how we can integrate clinical care pathways with standardized research approaches to optimize CSF liquid biopsy. So as everyone knows, brain metastases are the most common adult brain cancer, and for reasons we've discussed today, the frequency is rising. And despite improvement of local therapies, the prognosis continues to be poor. And classically, we think of the hematogenous route of spread for cancer to the brain. But are there potentially other routes of entry to the brain? And we've all anecdotally or clinically seen that there's patients with recurrent brain metastases that have very good systemic disease control. And classically, we attribute this to the blood-brain barrier, which is a structure that has evolved over millions of years of evolution to protect our brain from toxins in the blood, including chemotherapy. But what if the CSF is a potential nidus of entry as well? And for that, we can draw on some experience learned early on from literature in leukemia. So this is a relatively old study, I think from the 80s. It was an autopsy study looking at the brains of 126 patients with CNS involvement by leukemia. Among these, 70 of the patients had arachnoid leukemia at the time of autopsy. And if you try to correlate their disease stage from very early to advanced, you could see that very early on, the disease involved the arachnoid layers, and then as the disease was more progressive, it involved the pia and the parenchyma of the brain, and then causing gliosis, necrosis, and hemorrhage. And this is what led to the conclusion that CNS leukemia is primarily an arachnoid disease with cancer cells entering through the CSF. And this makes sense. The CSF is relatively rich in nutrients. It's relatively spared from immune surveillance. And we have the blood-brain barrier and the blood-CSF barrier to make the CSF a therapeutic sanctuary. And this is a very nice anatomical depiction of this. It was published in Nature a couple of years ago, showing the various paths that cancer cells can come from the body into the brain, but more specifically the CSF spaces. So classically, we think of disruption of the blood-brain barrier, but we have over here shown the blood leptomeningeal barrier. Here we have the blood CSF barrier. And then the more novel areas where we've seen recent literature actually show that the calvareal vessels are responsible as well. So you have the bridging veins that go from the skull to the CSF spaces, and these are very ripe areas for cancer cells to move through. And then also the dural lymphatics, which have been well established lately as potential culprits. So working with my dear colleague in neuro-oncology, Dr. Mike Clance, we wanted to see whether there's any CSF involvement in patients with brain mets, parenchymal brain mets, who do not necessarily have LMD. So in this time series study, looking at 204 patients with brain mets, none of them having imaging or clinical suggestion of LMD, we identified about 66 who were undergoing gamma knife radiosurgery and were good candidates for having a lumbar puncture. Here we have an even breakdown of male-female, average age 64, and predominantly lung cancer patients. We're also interested in seeing what proportion of these patients had tumor near a CSF space, defined as within 5 millimeters of sulci, ependyma, or major cisterns. And we found that about 85% of these tumors did come in to close proximity of a CSF space. What was more interesting is that we found that the greater the intracranial tumor burden, the greater percentage of patients who had positive cytology for actual malignancy. So you can see if the patient had one brain metastasis, 43% of them had positive cytology. If they had 3 or more, we're talking about 60 to 70% of them. And again, to emphasize, these are patients who did not have any suspicion of LMD. And then there's further mechanistic data emerging from our translational basic science colleagues. This was work done by USC Dr. Josh Neiman, but also colleagues from elsewhere, showing that breast cancer metastasis to the brain can be exacerbated with chemotherapy and through disruption of the blood CSF barrier. Specifically, they showed that increased expression of MMP9 led to disruption of the choroid plexus cells of the blood CSF barrier, but also this led to the mechanism of increased tau protein deposition and thus Alzheimer's. So this work here suggests that not only is chemo brain a real thing, which we've talked about today, but also it can exacerbate the likelihood of cancer cells, in this case breast, penetrating the CSF and metastasizing to the brain or causing leptomeningeal disease. So we talked about how recurrent brain mets are seen in patients with very good systemic control. Work by Dr. Brastianos from MGB has shown that there's this concept of branch evolution. More than 50% of cancer cells that make it to the brain have a molecularly different profile, actionable profile that's different from the primary cancer counterpart. So there's a need to know that when we're trying to tailor our treatments. I've shown our work on positive CSF in patients despite negative imaging. Could argue that this could be tumor shedding, but the pretty high percentage suggests that perhaps some of it is not necessarily just shedding. It could be entry. And I've talked about how mechanistically it's plausible. We talked about the anatomical pathways and the role of chemo in perpetuating this. So for all these reasons, I am a strong proponent of the fact that we should study CSF when it comes to optimizing the management of patients with brain mets. My lab is very much interested in CSF liquid biopsy. I specifically have an interest in proteomics. A couple of years ago, we undertook this systematic review to look at the state of the literature in CSF liquid biopsy when it comes to adult brain cancer, malignancy specifically. And this was recently published in the JCO. As you can see here, in general, brain metastases are the least studied. And among the very few studies that we found a couple of problems is that all brain metastasis pathologies are clumped together. So we kind of like the SRS world in the beginning, where we clump brain, breast, lung, melanoma, all of them together, which doesn't really allow us to get a granular understanding of what the differences are. And to further exacerbate the problem, a lot of times LMD patients are combined in their reporting with parenchymal brain metastasis patients. Other interest proteins were the most commonly analyzed, and most of them were biased approaches. So analyze an antibody-based approach looking for a particular marker rather than discovery-based approaches. We wanted to dive deeper into that by performing meta-analytic analyses. And to do that, we wanted to see if we can find a malignancy signature in the CSF by combining peptides that were common to brain mets, GBM, and lymphoma. And we also wanted to see if there are biomarkers that can help us distinguish GBM from brain mets from lymphoma. You can see here the YWHE peptide, which is part of a family of peptides that I'll talk about later, came up as a potential signature for malignancy in general. Specific to brain metastases, we found these two, IgJ and SHBG. So SHBG kind of makes sense. It's a sex hormone binding globulin, and there's some literature to suggest that in patients who have estrogen receptor negative cancer, it can promote the invasion of the central nervous system. But IgJ, on the other hand, it's an immunoglobulin. So question is this simply leakage from bloodstream? Is it contaminant? Is it a leaky blood-brain barrier? Or is it actually something that makes sense? So for this, we wanted to better understand if there's a blood-brain barrier disruption signature that can be detected in CSF. As we found in our own work and some other literature that we've seen, the YWHE peptide, which is part of the 1433 family of proteins, is commonly seen in malignancy and perhaps could be attributed to serving as a marker of blood-brain barrier breakdown. But on the other hand, it's also been seen in some neurodegenerative disorders, so further official validation of this is necessary. I talked about the IgG being immunoglobulin, so is this a leakage problem? So some of the strategies to account for this or try to address this that we proposed was looking at the protein albumin quotient, so coming up with a coefficient to divide the concentration of the peptide of interest that you're finding in CSF by the albumin concentration in the CSF to kind of normalize it, to account for the fact that potentially it's leaked from the plasma. It's not ideal. You can also try to filter biomarkers and basically get rid of samples that have a high concentration of albumin, but that can be problematic too. You might lose a lot of valuable information. And in general, I think a good idea is to, whenever designing prospective studies or retrospective studies, is instituting appropriate controls. So if we're trying to account for blood-brain barrier disruption, it's good to have disease, non-tumorous, non-cancerous disease that can show up with contrast enhancement on MRI, such as tumefactive MS or meningitis or other disorders that we want to use to eliminate the background noise and improve the signal. And here I've just captured some of the other peptides we found. So I talked about 1433. C3 is a complement for protein that's found in the plasma. Again, concern about leakage. And microRNAs, MIR21 was another one that was interesting, but I feel like these all need further prospective validation. Then the other topic that we wanted to explore was the question of sampling location. So at Penn State and I believe at MD Anderson, we're strong proponents of very early upfront Ommaya reservoir implantation in patients who have LMD, CNS lymphoma, or even GBM patients that seem to have cancer approaching the ependema and looking like very aggressive or recurrent cancer patients. So we get access through the Ommaya. but a lot of other places may get it from a VP shunt or a lumbar puncture or from the cisterns during surgery. And you can see we found that a majority of studies that in our review got them from lumbar puncture. Very few got them from Ommaya reservoirs, or many were not specified. But we know that there's a established rostral-caudal gradient of protein, specifically when you go from the ventricles, the space that's in contact with the tumor, to the lumbar spine. And this affects the concentration of proteins that you find. So what we propose is that when doing discovery proteomics, the proteins that you find in the CS and the lumbar space likely have offer greater specificity, whereas the ones that you find from ventricles or cisterns offer greater sensitivity in terms of looking for a particular diagnosis. So when doing biomarker development and ultimately we want to look for peptides that can be detected in the lumbar space, because what's the point of having a diagnostic marker that you need to open the skull anyways for? So when trying to develop biomarkers, it's important to prioritize high concentration ventricular biomarkers with the assumption that these high concentration markers are more likely to show up in the lumbar spaces. And again, going back to the standardization, we need to have adequate reporting of metadata. So location of sampling, what volume, et cetera, et cetera. Next is the question of cell of origin. So a lot of these biomarker studies, particularly protein and microRNA, they can be confounded by non-specific processes. With DNA and RNA itself, it's probably less of a problem because the genomic abnormality you find is very specific for the cancer. But with proteins, it's not necessarily easy to tell. And so some of the strategies we recommended to account for this include spatial localization studies. So for example, if you found a protein biomarker of interest, performing imaging mass cytometry, which is multi-layered tissue slice analysis with antibodies to confirm which particular cells or areas within the tumor microenvironment is that protein found in order to help us understand, okay, this is probably coming from the microglia, let's say. And then we can always leverage publicly available proteomic databases or single-cell RNA sequencing databases to, again, try to ascribe what the protein that we found in CSF, what cell could it be coming from. So I'll switch gears now to talk about some of the low input unbiased proteomics work that we did. This was a proof of concept study to see how low we can push the volume of CSF required. And as I mentioned, we got all our samples from a reservoir. We used the M-Stern method of processing samples for mass spectrometry, and we did perform external validation. This is a summary of our workflow. We had 20 NPH patients for non-tumor control, 22 GBM, 17 brain mets, and 14 CNS lymphomas. This is just table one, but what I want to highlight is kind of reflective of our practice. So whether it was our GBM patients or brain met patients, a good 2/3 of them had established leptomeningeal disease. So going back to that was a critique I pointed out in our meta-analysis systematic review, we were guilty of that as well. We're combining parenchymal brain mets with leptomeningeal disease, but also the lymphoma patients are shown here as well. So in terms of trying to identify particular pathways and diagnostic biomarkers, we use standard statistical methods and pathway enrichment analysis. We performed a similar approach to identifying malignancy signatures versus non-malignancy signatures. I'm sorry, this figure is not showing up well, but basically these 3 boxes are our own data in our discovery set. These 3 boxes are from the external validation that we did using a paper by Schmidt and colleagues published around the same time. And then the gray boxes are publicly available proteomic data from non-malignant neurodegenerative disorders such as Alzheimer's, ALS, and MS. And you can see that for the most part, our malignant signatures and non-malignant signatures validated well with the external study and the public databases. With an eye towards future clinical applicability, we wanted to see if there's any specific biomarkers that can help us distinguish disease as part of diagnostics. So a lot of focus on signatures, here the malignancy signature and non-malignancy signature, but we also wanted to see if there's any individual biomarkers. And we found GAP43 to be found in specific to GBM, TFF3 for brain mets, and CACNA2D2 for lymphoma. And so if you're positive for GAP43, this is the sensitivity and specificity. then we know that multiplex biomarker studies are perform better than models. So we wanted to see if we can have a triplex classifier. And here you can see if, for example, a CSF sample is positive for TFF3, but negative for GAP43 and negative for CAC2D2, you have a specificity of 0.81 and sensitivity of 0.88 for this to be a brain met sample. And just to note, TFF3 is the trifoil family of peptides. And in breast cancer, it's been shown to promote invasion of lymph nodes and bone. And this makes sense. The majority of our patients were breast cancer, the rest were lung cancer. So this is something that could be noteworthy and for future exploration. We also tried to leverage single-cell RNA-seq databases to see whether any of it was the biomarker source of origin. And interesting, not the topic of this lecture series, but GAP43 was specific to glial cells, for example, not monocytes or microglia. So suggesting, for example, when you're monitoring a patient and you're wondering if it's radiation necrosis or true tumor recurrence, if you have a high GAP43, it's more likely to be true tumor rather than representing immune cells. And finally, I'll talk about a roadmap to clinical applications. So as part of our work, and also I've been working with the Blood Pack group, which is a liquid biopsy group, and I've recently created a brain tumor working group to see if we can establish common data elements for CSF studies. And this is what we propose in terms of pre-analytical variables. And we find this super helpful when we find our own data and we want to try to externally validate it with other published work. And if we see differences, and this type of metadata pre-analytically can help us understand what the potential sources of these differences could be. So examples include how cellular was the sample, was there any blood contamination, what was the time to freezer, storage temperature, shipment conditions, etc. So on the left-hand panel, where I see this potentially fitting in a clinical workflow, there's absolutely zero evidence right now to propose CSF sampling in asymptomatic patients for screening purposes. But perhaps as the work gets stronger and stronger, one could start proposing studies, and if that works out, actually clinical workflow, to look at patients with high risk, let's say breast and lung cancer, who don't have established brain mets, based on the evidence I proposed early on, to look at their CSF and screen for possible early infiltration of the CSF by cancer cells as a means to have more closer surveillance or institute earlier clinical trials or target that space for therapy. In symptomatic patients, as long as feasible, we think lumbar punctures can help for diagnostic purposes, as long as the patient does not need imminent surgery or there's no contraindications to a lumbar puncture. And looking at the cisternal CSF can perhaps help with prognostic data. So, for example, if you have a high concentration of peptide X detectable in the Sylvan fissure when you're trying to split the fissure and approach towards an insular glioma, is that a particularly higher risk tumor that needs more monitoring later on? And then in terms of treatment, after you've instituted standard of care treatment, I am a strong proponent of being more open-minded, at least, towards upfront implantation of ventricular reservoirs, which serves the purpose of at least monitoring for treatment response and surveillance for tumor relapse, if not helping us in actual institution of therapy. So Dr. Glitza mentioned the work that they're doing with immunotherapy, and here at Penn State we do multi-agent chemotherapy, and we have also found some surprisingly pleasant surprise extended survivals in LMD patients with this approach. And then switching over to the research side, for discovery biomarker development, I think we take what we can, basically. Lumbar is okay, ventricular, cisternal from the shunt, it's okay. And various assays can be used, various analytes can be analyzed. And that's all that is great as long as we report the metadata, but also do our homework in terms of characterizing these biomarkers. So, for example, having good clinical correlates. How does your biomarker correlate with tumor burden? Is there any variation in terms of response to treatment, pre and post treatment? And then also trying our best to define the cell of origin through the strategies that I mentioned, and having some sort of a strategy to account for blood-brain barrier disruption, plus or minus grossly contaminated samples by blood. And then when it comes to actual validation studies, though, when we want to transfer this to the clinic, this is where prospective large sample sizes are necessary, and we need absolute quantification methods. So, for example, the work that I presented, it's the shotgun proteomics with mass spectrometry. This gives relative quantification, but once there's good promise that a biomarker is being seen first in data-dependent analysis, then data-independent analysis, then one can make the case of developing particular assays such as parallel reaction monitoring to actually quantify the limit of detection, limit of blank, etc., and then carry that into prospective studies and then the clinic. So parting thoughts, we need a concerted effort towards research standardization. There's tons of different assays, cfDNA, extracellular vesicles, proteomics, etc. And even within proteomics, you have mass spec-based, you have O-link, you have antibody-based methods, etc. So it's important to really understand what application we're trying to use this for, because the cost can be significantly variable, feasibility and manpower utilization can be quite dramatically different. And we're working on a paper to compare all these different proteomic methods, the cost, effort, and protein yield, and differences in enrichment. And at the end of the day, these are very precious samples. Ommaya reservoirs give you 10 to 15 cc's, but not everybody does that. So I think it's very important to be very open to establishing consortia and having workflows for data sharing. So we're working on with other colleagues to, for example, publish our IRB protocols and trying to advocate for more simpler MTA and data sharing agreements that makes this more feasible. And then some of the things is trying to think outside the box, and hopefully I've made the case for thinking about earlier Ommaya reservoir insertion. Thank you very much for your attention, and always happy to collaborate and hopefully see you at SNO.
That was a great talk. Thank you so much. I think, as I said, we'll keep the questions for the panel section. And with that, I will let Dr. Morris go next.
Thanks, Dr. Day. It is my distinct pleasure to introduce our next speaker, Dr. Christopher Alvarez Breckenridge. Dr. Alvarez Breckenridge completed his MD and PhD training at The Ohio State University, followed by residency in neurosurgery at Massachusetts General Hospital. He currently serves as assistant professor of neurosurgery at MD Anderson Cancer Center, where he leads a research laboratory focused on the complex interplay between tumor microenvironment and central nervous system tumors, while maintaining a robust clinical practice in both primary and metastatic CNS diseases. Today, he'll be speaking to us about the role of laser interstitial therapy in the treatment of spinal metastases. Welcome, Dr. Alvarez Breckenridge.
Great. Thank you so much for the invitation. And will you be posting my slides, or do I need to share them on my end?
If you're able to share them, that would be perfect. But if you want, we can also post them up.
Give me one sec. All right, great. Can you see my slides all right?
Yep, looks good.
Perfect, thank you. So again, thank you for the invitation to talk with you all today. Pivoting slightly towards spinal metastases and a treatment approach that we've been pursuing for the last several years here at MD Anderson, leveraging LIT for spine metastases, and particularly as a minimally invasive treatment approach for this patient population. So I have no disclosures, and just kind of following up on some of the prior discussions about LIT. We're using our laser fiber and our intraoperative MRI as a kind of treatment platform for patients with significant spinal cord compression. So you can see here in this third column, and our intraoperative MRI with our kind of laser fiber applied in proximity to the spinal cord. And I'll go into more detail about kind of the patient selection process and kind of the mechanics of how we do this, and then some of our outcomes. And so in the context of spinal oncology, LIT provides an alternative to conventional open separation surgery. It is important to keep in mind, though, that this is a combinatorial treatment approach where we're doing LIT and following it with spinal stereotactic radiosurgery, or SSRS, similar to what we would be thinking about if we were doing an open surgical approach. We think about this treatment for patients who have radiation refractory tumors. And then I think probably the most important thing to consider is patient selection in terms of things such as KPS, and patients who are medically frail. We tend to consider LIT as a great treatment option for those patients, and I'll discuss a little bit about that later. Patients who have medical comorbidities or complicating medical factors such as coagulopathies, or let's say they're Jehovah's Witness and are refusing blood transfusion, and they have a renal cell carcinoma met, doing a large separation surgery might be challenging or fraught with difficulties if we can't transfuse those patients. LIT provides a great alternative for those individuals. And then for patients who have widespread disease that may be progressive and really can't tolerate being off of systemic therapy for an extended period of time, LIT provides a great option for these patients as well, because a lot of the wound healing concerns that we might have with an open surgery, we don't really have those same concerns with LIT. So we'll touch on those later in the talk. But as you all probably are familiar with, spinal stereotactic radiosurgery has really, provided an alternative treatment approach for patients who have what was previously deemed radioresistant tumors, so tumors such as renal cell carcinoma or thyroid malignancies. But one of the critical aspects to this is that we have to be able to administer radiation at an adequate dose to the tumor. And when we're talking about tumor that's in close proximity to the spinal cord, that can pose some challenges. And so going back to kind of the Bilski classification scores, which many of you are probably familiar with, patients who have Bilski 1C disease, so tumor in contact with the spinal cord, or more significant disease, Bilski 2 or Bilski 3, those patients generally will not be great candidates for just upfront stereotactic radiosurgery because of the dose constraints to the cord. And so a separation surgery kind of outlined by kind of the Patchell study a number of years ago is really what's necessary to achieve adequate surgical decompression that can be followed with an ablative kind of radiation dose. In terms of outcomes related to stereotactic radiosurgery for the spine, at least the MD Anderson experience has demonstrated a 1-year local control rate of 88%, but recurrence will occur, and it's typically in the margin where there's issues related to dose restraints imparted by the spinal cord, or when the GTV kind of minimum biologically equivalent dose is less than 33 Grays. Thinking about other factors that may limit the efficacy of radiosurgery, tumor volume that's being treated with radiation that's greater than 50 cc's is associated with poorer outcomes, as well as sarcoma histologies. And so you can just appreciate there's quite a bit of heterogeneity when it comes to the radiation treatment planning based on what type of tumor we're talking about, what the volume is, and what that volume is in relationship to proximity to the spinal cord. And so this is an MRI of kind of a classic case that you all may be seeing on a regular basis. On the left, this is a preoperative image of a patient with significant epidural spinal cord compression with tumor confined by the posterior longitudinal ligaments. This patient would undergo open separation surgery with laminectomy and transpedicular approach, and corpectomy with a vertebral body reconstruction. And so on the right, you can see the post-op imaging with, circumferential CSF around the spinal cord. And so this patient had a great, surgical decompression followed by radiation, but not every patient can tolerate that surgery. And so it was in that setting that we sought out to develop this more minimally invasive approach using LIT. And so ultimately, there's generally 3 trajectories that we will pursue when trying to place our laser fibers, either a transpedicular approach, which you can see with the blue arrow on the right, more of a translaminar approach with the purple arrow, or a vertical approach, just shooting straight down the pedicle. And so on the right here, we have, a kind of example image of patient with, Bilski 2 disease, where we took a transpedicular approach for placing our laser fiber. We heat the fiber, and that kind of shaded zone will achieve an ablative dose of heat to kill that tumor. This is another set of imaging representations. The left image here, our preoperative T1 post-contrast scan showing our epidural tumor. The middle column showing our fiber placement, so the intraoperative MRI, and then a post-treatment scan. This scan doesn't come across quite as well as some of the later ones I'll show, but you'll see kind of a hypoattenuation on this MRI showing the area of treated tumor. And just conceptually, we know that the dose constraints to the spinal cord are 12 gray, and typically we're trying to achieve 24 gray in a single fraction to the tumor in the vertebral body and in the epidural space. But due to the dose constraints of the spinal cord, we're typically underdosing this area in green. And so that's where we are really trying to place our laser fibers and eradicate the tumor in that kind of green zone, because we know that otherwise the tumor in that location would be underdosed. And again, here we show where our laser fiber is and kind of the region within the vertebral body and epidural space that will be treated, and kind of set the stage for the subsequent radiation. Here we have a kind of example of a patient, 50-year-old individual, squamous cell carcinoma with sphenoid sinus, undergone multiple lines of treatment, ultimately has progressive disease at T4 and T8. And so in the second column, you can see, our significant area of contrast enhancement with cord compression, and the options here would be, a pretty extensive, open surgical decompression, corpectomy, reconstruction. But, in this case, we thought this individual may be a prime candidate for this more minimally invasive approach. And so this patient underwent 4 fiber placements for the superior lesion and 4 fibers for the inferior lesion. In the third column here, we have our MR thermography imaging showing in orange the area of ablated tumor. And then on the right, this is our post-treatment subtraction scan that we obtain after every, once we've completed our treatment, while the patient's still in the intraoperative MRI, we'll get this, and you can see kind of the hypo-intense area, kind of in black, is the area of treated tumor. And so, there's a clear treatment effect in that epidural space, and that was at T4. And then again, we had disease at T8, and so we placed 4 fibers at that location as well, and similarly had a encouraging treatment response that we saw intraoperatively. These patients will typically get a CT myelogram after surgery. You can see here on the right, this was a CT myelogram 5 days following LIT. There still is some mass effect from that treated tumor, but the key thing is that is not viable tumor, and it doesn't have to receive that full 24 gray of radiation because it's undergone this thermal therapy. 10 days after surgery, the patient's undergoing radiation, 24 grays and 1 fraction to both T4 and to T8. And then postoperatively, we see reconstitution of the spinal canal, no evidence of any spinal cord compression or disease recurrence. And in this patient, we're tracking out 16 months after surgery, and again, a encouraging clinical response for this individual. And so we've published our kind of institutional experience in a number of publications. Our first paper, we were just summarizing the first 11 patients that we had treated, and I think the take-home message from that paper was looking at the pre and post-op Bilski grade for these individuals, and saw on average patients were undergoing treatment with Bilski grade 2, and after surgery at 2 months, their Bilski grade was down to 1B. Additionally, we looked at pain metrics. These patients had significant reduction in pain at multiple time points post-surgery, and an improvement in their quality of life metrics. We've subsequently done analyses of patients, 120 of our cases, and similarly have recapitulated that decrease in 2 Bilski grades from pre to post-op lit. Our failure rate has hovered around 20%, where these patients have required subsequent decompressions or redo lit. And then 10 patients ended up having disease progression requiring transition to hospice. In this study, our median time to failure was approximately 5.5 months. And then various complication rates, but as I'll show later, this complication rate was actually more favorable than when we will do open separation surgery. In addition to metastatic disease, we have also applied lit for patients who have primary diseases of the bone, patients with chordoma who have metastases. And so this was a patient who had a clival chordoma, underwent multiple rounds of treatment, and ultimately developed a metastasis at T2 and T3. And so, we considered, lit as a reasonable option for this individual. You can see the extent of spinal cord compression here. In this individual, you can see we ended up taking 6 trajectories. This was on the left, an X-ray that was obtained intraoperatively with our catheter placement prior to getting our MRI. And what you'll appreciate here is that similar to what we've seen in other metastatic histologies, post laser treatment, we see a significant reduction in our contrast enhancement in this epidural tumor, really facilitating subsequent radiation. I think this picture here is actually maybe one of the most striking things to take home when thinking about spine lit, is that in our hands, patients who undergo open separation surgery, I typically tell them to expect to be in the hospital for 5 to 7 days, that we're going to be dealing with kind of pain management issues related to the extent of exposure and the fusion. And while we ultimately get those things under control, it can be a bumpy road. That is kind of in contrast to the narrative that we tell our lit patients, where I generally expect to be discharging these patients home post-op day 1. They typically have pretty minimal pain after surgery, and are doing quite well, and are very happy with how they're feeling post-operatively. So that was what we experienced with this individual. Discharged home post-op day 1. Post-op day 3, the patient underwent SSRS, 24 grays and 1 fraction, again highlighting the difference from what we would be thinking about in an open approach. The incisions are quite small, and we typically don't run into issues with wound healing complications, and so we're really able to transition to post-op radiation within 1 to 3 days after surgery, if everything is planned accordingly with our radiation oncology colleagues. And then here's our post-op imaging for this patient, 2 months post-op, no evidence of any disease recurrence. the other factor to take into account when thinking about surgery for patients with spinal metastases, in addition to kind of tumor causing compression on the spinal cord, is more biomechanical related issues and instability. And so we often are thinking about having to combine a stabilization procedure with our lit workflow. And so these are just some representative images of an individual who ended up undergoing, lit, and then also required a percutaneous stabilization with cement augmentation that was essentially tacked on in the same surgical procedure. So once we did our laser ablations and the intraoperative MRI suite, we proceeded with our percutaneous stabilization. In some situations, we'll stage this over 2 days. It really is a kind of patient dependent factors that we take into account. But we've had encouraging results by combining our lit procedure with a stabilization procedure, as you would normally be doing in an open case. Here's our imaging for this individual. Significant spinal cord compression before our intervention, and then at 2 and 12 months post-op, no evidence of any disease recurrence. And then here we have a 87-year-old female, history of non-small cell lung cancer, prior round of conventional and stereotactic radiosurgery with disease progression at T11, T12. Again, taking a patient at 87 for a 2-level corpectomy and at least 2 above, 2 below fusion is kind of an onerous task. And so we will think about lit as really an ideal treatment approach for these types of patients. So thinking about the strategy of where are we going to place the laser fibers, prior to every case, we spend a lot of time looking at the pre-op imaging and the anatomy of where the tumor is in relationship to the bone, and what trajectories we can reasonably use to get adequate tumor coverage. And so here we have a right transpedicular approach, and then a right-sided translaminar approach, and then a left-sided transpedicular approach. And so, just for this level, we're taking 3 trajectories, and honestly, every tumor is going to be different, but it really requires some thought preoperatively to ensure that we think we have an adequate plan. This is just some of the mechanics of what we do in the operating room. Once the patients are flipped prone, we'll place fiducial markers on the back in the region of interest where we'll be doing the procedure. We affix a spinous process clamp for an array, and then prepare the patient for a registration MRI. Once the MRI is completed, we register off of those fiducial markers and then can come up with our kind of intraoperative trajectories. And so we'll draw out a kind of 3D model of the tumor and then use our neuronavigation to identify what are the trajectories that we need to get adequate coverage over the lesion. Once that has been completed, we'll use a navigated Jamshidi to dock onto the bone and then enter into the tumor. We'll typically get an X-ray just to confirm that our docking is consistent with where we thought it would be on our kind of planning imaging, and place a K-wire down through the Jamshidi, remove the Jamshidi, and then place an angiocath over the K-wire. And we'll do that for each of the trajectories. So that's what you see kind of in the middle top column. And just drawing your attention to the lower right-hand column, this was a intraoperative MRI that was obtained prior to our thermal ablation. You can see each of the individual black dots in the tumor is representing where each of those catheters is located and ultimately where the laser fiber will be placed. And so you can see from a rostral caudal orientation that we have extensive coverage over that tumor in the spinal canal. We have a video here which kind of summarizes some of the workflow. So here we're using our navigated Jamshidi to advance into through the trajectory that we had planned. We'll bring in our X-ray to confirm appropriate location, and then place a K-wire down. We'll remove the Jamshidi. And then place the angiocath over the K-wire. And then place a stylet through the angiocatheter. And this is just another patient, but once the trajectories have been finalized and the catheters are in place, we prepare for the intraoperative MRI. Once everything has been sterilely covered, we'll remove those stylets and place the laser fiber through the catheter. And depending on the number of trajectories, we may use 2 laser fibers. Just kind of depends on a patient-to-patient basis. And then we prepare the patient for MRI. Once we get our intraoperative MRI, we'll set our temperature targets for our high limit and really critically our safety limit of usually either 48 or 50 degrees Celsius. And that's really at the interface between the tumor and the spinal cord. And then we'll proceed with our laser ablation. And so we'll have our anesthesiologist in the operating room while we're kind of outside, allowing them to ensure that the patient is in ventilatory arrest for usually we say 2 minutes at a time. And for each trajectory, we'll typically do 1 or 2 treatments. And so here is just an example of our intraoperative scan with our placed catheters showing trajectories coming bilaterally. And this is an MRI just scanning through where you can see kind of sequentially kind of the location of where we have placed all of our fibers. Once we've undergone the ablation, you can appreciate here in the lower right-hand corner, kind of the area of contrast enhancement is the tumor that we were attempting to ablate. Following ablation, we'll do a subtraction scan, and you can see now all this area outlined in black is our ablated tumor. And so this is really setting us up ideally for our postoperative radiation so that we can safely give radiation around the spinal cord. In terms of how LIT compares to the more conventional open corpectomy type of surgery, we published our experience of 40 LIT cases with a kind of matched cohort of 40 vertebrectomies. And what we observed was a significant reduction in complication rates in our LIT cohort, both minor and major complications. We consistently saw a reduction in Bilski grade across both, although the extent of reduction was greater in our open surgical cases, which isn't overly surprising. But regardless, we were still able to achieve that kind of 2-grade reduction with LIT. Looking at other parameters that varied between the 2 cohorts, there's a significant reduction in estimated blood loss and length of stay in our LIT cohort. So you can see on average patients are staying 3 days, but oftentimes, like I said, they're leaving in 1 day. And then the time to systemic therapy was also significantly reduced in our LIT cohort from 24 days to 59 days in the open surgery. And then similarly, time to radiation is significantly reduced in our LIT group compared to open surgery. So comparing approximately 7 days to 35, and that 7-day mark can honestly be reduced even further if there's adequate planning with your radiation oncology colleagues prior to surgery. In terms of kind of clinical equipoise, we looked at the progression-free survival between our lit group and our open surgery group and found that there was no significant difference, suggesting that there is, in fact, equipoise between these two treatment approaches. And then more recently, we published our experience with 129 patients with metastatic disease in the thoracic spine. And in this cohort of patients, 80% did receive radiation, of which 68% received SSRS. In this cohort, the median time to radiation was 5 days. The 1 year freedom from local failure was 80%, and the 1 year overall survival was 78%. When thinking more about this freedom from local failure and what factors might be contributing to a poorer response, we looked at the kind of location of where the disease was at the time of treatment. And what we found was that patients who had foraminal disease tended to do worse, in contrast to patients who had tumor confined to the vertebral body, confined by the posterior longitudinal ligament, or located in the posterior elements. Also, patients who had higher post-treatment Bilski grades tended to do poorer. And so we looked at this both with univariate and multivariate analysis, and it bore out in both of those analyses. And so, I think the take-home message is, there are certain patients where spine lit may work best, and it's important to think how that fits into the kind of standard criteria that we think of. So, many of you are familiar with the NOMS criteria for decision making of patients who present with spinal metastases. How does lit fit into that criteria? And so we typically think of the indications for lit being patients who have disease in their thoracic spine between T2 and T12. These patients should be essentially neurologically intact from a kind of motor perspective. So no motor deficits, spinal cord compression between 1C and Bilski 3. Typically anything less than that would be amenable for stereotactic radiosurgery without a surgical decompression. As I mentioned, the patients that do best really have tumor contained by the posterior longitudinal ligament. And then, these are also patients who may be particularly frail or have other factors that would make them high risk for open surgery. In terms of contraindications for lit in the spine, tumor in the cervical spine or lumbar spine, patients who have motor deficits, patients who have prior spinal hardware or an inability to obtain an MRI. And just in terms of some of the anatomic considerations, generally we're a little bit reluctant to offer lit for patients who have kind of extensive epidural creep. And so this idea of having tumor confined by the PLL and not creeping rostrally or caudally, those tend to be the patients that we gravitate towards this procedure. And so we talk a lot about how to, expand this treatment modality outside of our walls. And there's various, factors that need to be taken into account. So, it's critical to have an intraoperative MRI. Beyond that, it really also requires a multidisciplinary team combining the neurosurgeons with the radiation oncologists and the imaging physicists, to understand the capabilities of what this treatment can offer and how it interfaces with the postoperative radiation that these patients need to receive. There's continuous improvements that can be made in terms of workflow related to hardware and software and partnership with industry. And I think we heard some really impressive data about how lit for cranial malignancies, either primary or metastatic disease, has really taken off as we've been able to leverage kind of a multi-center experiences and kind of integrating that data together. I think moving forward, it would be ideal, to be able to expand this outside of, MD Anderson and integrate data from various institutions to kind of refine maybe how we think about treating these patients, to think about potentially combinatorial strategies that might be able to be added on to this local therapy. And then finally, there's, kind of financial considerations that have gradually gotten better over time. I know that when this started, it was very challenging to get financial coverage for this. And normally, we're still having to have peer-to-peer conversations with the insurance companies. But, now that we have the literature showing, the benefit of LIT, how these patients are getting discharged sooner, having less complications, typically the insurance companies are quite amenable to this intervention as they realize that the alternative, classic open separation surgery would actually require these patients to be in the hospital quite a bit longer. So just like to thank you all again for the opportunity to talk with you, and thank my colleagues here at MD Anderson and the spine group. Dr. Tatsui is really the founder of this treatment modality and has really been a pioneer in this, and then Dr. Rhines and Dr. North. So thank you very much.
Thank you. That was a fascinating talk, and I've been like following Dr. Tatsui's work for a while now, so that's what kind of led me to bring you guys in, because I think it's a fascinating field, and getting more people involved in this kind of surgery would be great. That being said, our next speaker, I think, is running a little late. She's wrapping up her interviews, like residency interviews, so she'll be available at 12. Hopefully she'll be able to. Oh, she's here. I see a chat that she is able to join us. So our next speaker is Dr. Mariam Rahman, who is an associate professor in Department of Neurosurgery at University of Florida. She's a highly accomplished surgical neuro-oncologist and is considered a national leader in the field of brain tumor. She has a federally funded research lab that focuses on identifying immunotherapy approaches, including combining immunotherapy with MR-guided laser ablation. And today she's going to discuss laser ablation for brain mets.
Thank you so much, Mahua, for the great introduction. I appreciate you. And I'd like to thank you and all the organizers for inviting me to speak today. And I apologize if anybody was waiting for me, but I will talk about laser ablation for brain mets. And because we were doing residency interviews, I didn't get to send it into the earlier talks, but I'm sure they were amazing. And so if any of this is redundant, please forgive me. And I don't have any financial disclosures, but my main disclosure is that the work that I'm going to discuss is only possible, and most of it is performed by other people. And I am really blessed to work with incredible people, both clinically and in the lab, who make all the work that I'm going to present today possible. And really special thanks to Frank Bova, who runs our computer-assisted surgery program. He invented the radiosurgery program here decades ago and helped me build the mirroring LIT system, and helps me carry out the LIT brain met program that we have here at UF. So we're here because, as most of the people in the audience likely know, that brain metastases, even today, are associated with a horrible prognosis. And so median overall survival in the setting of cancer, once brain mets are identified, is about 14 months. And most therapeutics do not cross the blood-brain barrier. And so we really are looking for options beyond just traditional surgery and radiation, which is really our best treatment options right now in our arsenal. And what we're really going to discuss today are indications for LIT for brain mets, the methods that we use here to perform brain mets, and then how we developed a mirroring LIT system so that we could ask some preclinical questions that aren't currently possible due to limitations in tissue sampling after a patient undergoes LIT. And so putting a laser into tissue and heating it is nothing new. That's been going on for decades. And the issue for us as neurosurgeons really was the skull and the inability to visualize the laser and know how much heat we were generating. And so the two advances that made LIT possible were the ability to cool the laser probe to prevent charring of tissue to the end of the laser probe, and then real-time thermometry using MRI. And that allowed us to then safely be able to put a laser in, turn it on, not have it char tissue, and then be able to see the heat map that we're generating. Although a little bit imperfect in terms of its how detailed the information is that we get voxel wise, it's still a general guide, so we know what we're doing when we turn the laser on. I didn't get a chance to sit in Eric's lecture, so I don't know if he discussed these things, but right now on the market, there are two options, Medtronic Visualase or Monteris Norblate. They're essentially the same in terms of ability to deliver heat to a lesion. So this is a very, stereotypical lesion that you might see in somebody with cancer. This is a left frontal contrast enhancing lesion. It's very spherical. It has central necrosis. It's associated with cerebral edema. And it's usually at the gray-white junction, very common place to see a brain met. And when we think about treating with laser ablation, the questions that we want to ask ourselves are, the mainstays of treatment right now for brain metastasis really is surgical resection and or radiosurgery, because we have class 1 evidence, phase 3 randomized control trials looking at these treatment modalities, mostly in combination. And we know that they prolong both overall survival and progression-free survival. And so the role of LIT, and especially in my practice, is really in the setting of recurrence. And so we primarily try to use surgery and radiation in different combinations to treat people up front. And then when tumors recur, that's really when we start pulling LIT out as a treatment option. The limitations of LIT is that, honestly, because of the laser probe and the way the light emits from it, it's light-based heat. And so you're really limited to about 1.5 centimeters, radius, and a total of a 3 centimeter diameter size lesion you can create with your LIT. So you can treat lesions larger than 3 centimeters in diameter, but then you're often talking about multiple trajectories. And so, treating through one trajectory, you think the laser out, putting it through another trajectory. And in general, as the size of your treatment area increases, your risk of postoperative edema also increases. And you're definitely, this is thermal injury to tumor tissue. And so you can imagine that postoperatively, cerebral edema can be an issue, especially if the lesion you're treating is quite large. But the benefit of LIT, in addition to being a treatment option in the setting of recurrence, is that it allows for tissue diagnosis, because we're going to do a biopsy at the time. And so if there's any question about radiation necrosis versus tumor, this is helpful. The other benefit is that LIT is beneficial for both. It is very effective for growing radiation necrosis and for growing tumor. There's a lot of data that comes out of other groups, Rutgers and other folks, demonstrating that it almost doesn't matter if it's radiation necrosis or growing tumor in terms of whether or not you treat it with LIT. But obviously, if it's radiation necrosis, those patients have an excellent outcome and overall tumor control at follow-up, because LIT and thermal burning of the radiation necrosis lesion is very effective. But just like surgery and radiosurgery, you have to be able to burn most, if not all, of the enhancing tumor tissue that you can see on imaging. And so if you are, when we're treating these lesions, the software uses something called the Arrhenius equation. And I'm not going to claim to know anything about the equation other than it exists, which is really an equation calculating, your temperature based, your tissue injury based off of temperature and times. You can imagine if you get to a higher temperature, like 60 degrees Celsius, you need less time to kill that tumor. If your peak temperature is like 42 Celsius, you're going to be on the pedal for longer to keep that laser on. But essentially, the software uses the MR, phase shifting data to give you this thermal output, and you'll have, at least with the Monteris Norblate system, they'll give you a kind of an estimation of the tissue that's been heated but is reversibly damaged, and then tissue that's been heated for long enough that it's permanently damaged. And those are indicated by yellow and blue lines. The yellow line is reversibly damaged, blue is permanently. And so you really want that blue line around the area of contrast enhancement to at least 80%, if not greater than that, to have good progression-free survival. Otherwise, you're not achieving much. And, just like I had shown previously, but this is other data showing you that, tumor and radiation necrosis do matter in terms of overall progression-free survival and overall survival. But a lit, if you're getting a good ablation around the enhancing area, can really perform similarly to having surgical resection of the lesion. And the additional benefit of lit is that it's less invasive and patients will go home sooner. And so you can potentially obtain a faster recovery. Okay, so how do we do it here? So I'm just gonna, so we published this paper in 2018 describing how we do lit awake without general anesthesia. And at the time, you know, necessity is the inventor of, you know, once you have a need for something. So at the time when we first established our lit program, we had not yet built our new tower where we had intraoperative MRI capabilities. And so our lit system was such that we were placing the laser, the bolt and doing the stereotaxis in the OR, but then having to transport patients to another building to actually use the MR system. And so doing this awake made sense for us, and that's why we did it that way. And so we have now since built a new tower. We have intraoperative MRI, and so now most of our patients are asleep under anesthesia. But the most important thing about lit, which is also true for radiosurgery, is stereotaxis. So you know, you really want to have the laser probe down the trajectory of the tumor such that when you turn the laser on, you're really kind of being able to in that entire volume of tumor have laser ablation. And if it's a little bit off and you're kind of in the side of the tumor instead of down the center of it, you can imagine you turn it on, you're going to treat some tumor, but you're also going to get collateral damage on the other side treating normal brain. So you want to avoid that. And so we do that using a frame-based stereotactic system. Everyone has a little bit different take on this. And the other thing that we do is we often, this is Frank Bova's hand here, and this is a 3D printed model created, and we had pre-planned this patient who had a deep lesion, and we were having two trajectories, one up here and then one kind of occipital. And so the benefit of being able to mark this on her scalp before we put the head ring on is then when we can ensure that the post of the head ring won't mess with one of our trajectories, especially if it's an occipital trajectory. And you may need more than one trajectory if it's not a perfectly spherical lesion or if it's a little bit larger. And then because we use this in the setting of recurrence, oftentimes we're getting a pre-op CT to ensure that we avoid the edges of the bone flap or plates. So because we do need a solid piece of bone to be able to put the bolt in. Awake versus asleep, most of our cases now are asleep, but we do have, because we have large experience of doing these awake, we are comfortable doing that and how we position the patient in MR and secure their head. And so we do have a great way of doing that in case we were worried about someone's neuroexam or where the lesion is in relationship to something eloquent. And obviously they get a biopsy and then we place the neuroblate bolt. And so this results in something like this in the operating room. I promise I did not shave this patient's head. He came in bald. I don't shave hair like this. But this is, you know, we put the head frame onto the head ring that was placed on pre-op. We use that for our planning. So that allows us to stereotactically place this bolt through the skull. And then this bolt will help guide the laser probe directly into the lesion that we're targeting within a millimeter of accuracy. And so this is basically what using the NeuroBlate software, what this all looks like when the patient's in the MRI scanner. So we're sitting in the MRI control room and the laser is in, and you can see here, this blue line here is kind of like the tip of the laser. So we kind of advance it using a little robot to the deepest part of the enhancing portion of the tumor. You can see here, we have to take a trajectory that avoids the bone flap here. So this patient's had prior surgery. So that's why we didn't take this trajectory. And then as we turn the laser on, and here's the panel just showing you kind of the output parameters that we have control over. And then we get a yellow line, which grows first, and then the blue line, which is tissue that is permanently been heated for long enough that is permanently dead. And so this is actually one of Eric's publications, along with one of the neuro-oncologists who used to be at WashU, was at UF and now moved on to USC. But we can leverage this technology to open the blood-brain barrier. And so there's a temporary opening of the blood-brain barrier that's been demonstrated now using MR, as well as circulating markers of brain-specific enolase. So you can theoretically, the drugs that you give that normally don't cross the blood-brain barrier, if we deliver them within a few weeks of lit, you're theoretically getting higher intratumoral drug concentrations than you otherwise wouldn't. Brad Elder and his team had published this, and this is, you know, we don't know a lot about what happens to tumor tissue post-lit because we can't biopsy it after the lit, right? We're done after that procedure. And this was a case report where he had treated somebody with a tumor. They had kind of significant edema post-op, necessitating take back to the OR. And in doing so, when they analyzed the tissue by H&E, they found a huge number of macrophages, or these CD68 positive immune cells. And mostly what they found was central coagulant necrosis, this granulation of tissue with the macrophages, and vasogenic edema. And so we really here we're at UF, we're questioning, like, what does happen to the tissue and what are the kinetics of that? And then to answer that question, we were like, we have to be able to create a preclinical model system to do that, because I don't think we can be able to do that with human samples. And so, there are a ton of reports right now of using LIT in addition to opening the blood-brain barrier, of it resulting in a robust local immune response. And so this was a paper out of the Miami group with Ashish and others, Michael Ivan, demonstrating in patient, in a small number of patient samples, that you can get this immune response. This has been shown in other types of cancer as well. And so we were like, hey, can we demonstrate that here? This is a paper that some of our residents wrote along with our chief of neuro-oncology here, Ashley Giacetin. And this was patients enrolled in one of our clinical trials, where essentially they were randomized to either LIT plus PD-1 versus a craniotomy plus PD-1 for recurrent glioblastoma. And this was just a couple of patients, pilot samples, and this is in the peripheral blood. And you can see that they had an interferon gamma increased signal within their peripheral blood mononuclear cells that increased over time post-LIT. So pre-MLA is pre-MRI guided laser ablation. And so patient 1 and 2, so it's a small number of patients, but it was interesting enough that it piqued our interest. And so we did design 2 clinical studies, which are both closed to accrual and are in the data analysis phase, and they look exactly the same, except one was for recurrent GBM and the other one's for recurrent brain mets. And it was essentially, LIT plus Pembro, and the primary outcome measures were immune markers, peripherally circulating immune markers, and then secondary outcome measures were progression-free survival and overall survival. And this was our brain met study, TORCH study. So we were like, okay, how can we bring this back to lab? Also, I'm talking a lot. If anyone has questions, please feel free to raise your hand or interrupt me. And so we were like, okay, how can we do this? So we purchased a laser that's also a 1064 nanometer laser, which is similar to the output of the clinical system. And we first tested this in just chicken breast tissue that we got from the grocery store. And we wanted to make sure that we were able to figure out, okay, what are the maximum temperatures we're getting in tissue that has kind of similar water content to brain tissue, depending on what the wattage output was of the laser. So we use these curves to essentially create a system where we could reliably turn the laser on and achieve a particular temperature for a certain period of time. But to monitor this, we didn't want to use MR thermometry, because in animals, the expense and the having to keep the animals under anesthesia and the expense of using the MR system, we were like, can we just do direct thermometry with the thermal probe? But then using our stereotactic system, we had no way of really introducing the laser and the thermal probe just at the same place every time, so that we knew that our temperature readings would be accurate every single time in every single mouse. And so then this took us, Frank Bova and a really talented grad student who's giving his thesis defense today from my lab, and he designed several iterations of an adapter that we could add to the stereotactic frame that would allow us to reliably place the laser and the temperature probe, so that they would be exactly 2 millimeters apart every single time we did surgery on one of these animals, these tumor-bearing animals. And so this is the final iteration that we're currently using now. So they're kind of side by side here, and this is what it looks like in real life. And so this allows us to now, based on our wattage output curves, we know what wattage output we need to achieve about 42 degrees Celsius for about 3 minutes, and that reliably creates a lesion that looks like this. And these are glioma-bearing mice. And then this was in our KR158, which is an aggressive glioma model that we use in the lab. This was the survival advantage those mice had with LIT, which is exactly what we wanted to see. We don't want to cure mice with LIT. We don't have some crazy survival advantage, because this is probably similar to clinical reality. So once we had this established, then our question was like, what can we do with this? Well, other folks, Albert Kim and Eric's on this paper as well, demonstrating that this is direct evidence in a preclinical model that you open the blood-brain barrier and you get these large molecules that normally can't cross the blood-brain barrier into the brain tissue. And so our question really revolved beyond that to, okay, what is the immunologic response? So the first thing we did was take B16F10 ova, which is a melanoma model system, and we were like, okay, can we induce, and this tends to be an immunogenic model, so this is why we want to start with this first. Can we demonstrate after we treat with that lit system that we created that you get an immune infiltration within a tumor microenvironment? So this was 2 days post lit. So lit was done on day 7 after tumor implantation, and then we collected tumors and performed flow cytometry 2 days later, and we saw a statistically significant but not super robust increase in CD45, which are immune cell positive cells, as well as increase in microglia, CD45 low and CD11B positive, like resident microglia within the samples, but it wasn't crazy. So at the same time, we looked at T cells. We saw an increase in CD3 T cells, an increase in NK cells, which was exciting, but again, statistically significant, but nothing like life-changing. So we decided to change to add to the experiment, and this time, same thing, same model system, B16F10 ova melanoma, and they had lit, and then we collected tumors 2 days later, but also 10 days later. And now we saw like a very robust immune infiltration within the tumors in the 10-day group, and we included in here sham, which are animals that where we put the laser into the brain, but we didn't actually turn it on. And you can see in the lit groups at 10 days, you get this increase in CD3 positive T cells, increase in CD8 positive T cells and CD4 T cells, and those included effector memory and central memory T cells. So this was suggestive that we're getting some type of immune infiltration within the tumor that could then be leveraged. It's an actually adaptive infiltration. And at 10 days, we're seeing this much more robustly compared to the 2-day mark. We looked at other immune cells as well, so you actually get an upregulation of almost everything, including resident microglia and bone marrow derived macrophages. And so we're like, okay, well, can we potentially leverage this using PD-1? And so I don't show it here, but the first experiment was just with adjuvant PD-1 plus lit. We didn't really see a big difference. So we're like, okay, maybe the drug needs to be in the system before lit. And so we compared again, B16F10 ova, and the groups were untreated, PD-1 alone, lit alone, and then PD-1 delivered before lit, like the day before, and then adjuvant was lit followed by PD-1 treatment. And most of our analysis in terms of immune cells, CD3, CD8 cells weren't different, but activated CD8 T cells, which was CD44 positive CD8 T cells, were increasing in the neoadjuvant group compared to the other groups. Again, not hugely different in terms of the actual percentage, but enough so that we were like, would this correlate with a difference in outcome? And so the survival analysis is actually the experiment we're currently performing. And if we, with a significant interest that if we could leverage this immune response with lit, that could potentially be really interesting. So in summary, lit is effective for radiation necrosis and recurrent brain mets. So in the recurrent setting for brain mets, it's really useful. We do see a robust and diverse immune response in the tumor microenvironment post-lit, and so we really think that there's really a potential for lit with immunotherapy in this particular patient population. Thank you so much, and I'll take any questions.
Thank you so much, Dr. Raymond. That was a great talk, and I would invite all our panelists to come back and we can have a panel discussion.
Yeah, I agree. These talks were amazing. What you guys are doing with laser interstitial thermal therapy completely blows my mind. I'm texting with Dr. Krukoff during you guys' talks and just sitting here in awe with the amazing skill and precision with which you're utilizing this tool. There were a couple of lit specific questions that came into the chat. One's an easy one. I'm hoping, Dr. Alvarez, is this an awake procedure, or it looked like the patients were out being in the prone position?
Patients are asleep with general anesthesia.
Okay. All right. And then I know you alluded to this in your last slide, but one question I had, just because in my world of radiation oncology, trying to get insurance approval for something that I think is always the right thing to do is always a struggle. But what does insurance coverage look like for spine lit? I know that just having worked with Dr. Krukoff, that doing these things in the brain have been readily approved, but how does that process look for spine?
Yeah, in my experience, we're typically talking to the insurance company, before the procedure with the peer-to-peer. I think because we have data now that we can reference, that goes a long way to ultimately getting the approval. So, in my experience of doing these cases, I haven't had insurance company deny lit in any case thus far.
Okay, great. And then there was another question just with regard to
Joe, sorry to interrupt. Can I
Please,
follow
yeah, no,
up
go
on
ahead,
that,
Max.
Chris? So, what when we first started doing a lot of brainlet here, virtually all of them got initially denied, and then we'd go through the appeals process, and they got appealed. Eventually, we sort of developed like a Wisconsin policy within United Healthcare and a few others, and then now they're sort of all streamlined. But in my experience, the thing that sort of got us over the finish line wasn't so much the data. I felt like I could cite the data out my ears and they wouldn't really care. It ultimately was the position statements between the NCCN and the CNS and the AANS on appropriate use and guidelines. Because they'll always say, well, there's no good data to support this. And in neurosurgery, there's no good data to support anything. But in the absence of, a prospective randomized controlled trial, the next best thing that they seem to listen to are organizational opinions. So is that something you guys are working toward with SpineLit to get the CNS and AANS to issue a position statement, maybe to try to get a line item with the NCCN? My guess would be those would be big hurdles to which once you get past, would probably get them insurance companies to listen.
Yeah, no, that's a great point. It's something we haven't pursued, but now that you bring that up, I think it's something we can definitely explore. I think it will probably make our life significantly easier if we could get, kind of organized neurosurgery, to back what we're doing. And I think it would also then help, to go down the road of, kind of the getting more institutions involved as well.
And I guess along the procedural line, there is a question about if they're under general anesthesia, how, in case of cord compression, are you monitoring spinal cord function?
Yeah, so it's for that reason why, we're setting those temperature limits right at that interface between the spinal cord and the tumor. And so, from case to case, our trajectory may be, closer or further away to the spinal cord. And so those temperature threshold or cutoffs, which ultimately just shut off the laser. So if we hit 48 degrees, the laser shuts off. And so that's the safety, safety valve essentially that we have for this procedure. And based on how you place your trajectory, may dictate that you're having to do multiple rounds of ablation because after 45 seconds we're triggering the shut off. And so it can really vary from case to case, but the more of these procedures you do, you get a better sense of how far you need to place your laser fiber away from the spinal cord and how readily certain tumor histologies burn compared to other tumor histologies. So I guess this goes back to the greater point of more experience, multi-institutional experience to kind of guide how we plan these cases.
I did have another question just for all of the people doing lit on this call. I mean, obviously the overwhelming majority of articles that have been published and the data that's available to us is surrounding malignancy and cancer. We had an interesting discussion last night at our panel dinner just with regard to the complexities surrounding multiply recurrent meningioma. Was wondering if there are other pathologies that are being explored at this point in time, or if you guys are utilizing the device in an off-label way to help manage that challenging disease process, especially for the difficult locations that those tumors tend to arise.
I can talk about my own personal experience with that. We've had very little success with doing that. Sometimes you'll have these like multiply recurrent tumors and we're like, well, let's do lit because there's nothing else left. And usually those patients are on a growth trajectory that, lit is an adjunct to something systemic for these types of like multiply recurrent, really, resistant tumors. And so lit will achieve some amount of tumor debulking for a period of time. But if you don't have a good systemic therapy then to proceed with, then it usually doesn't work. And so in the small handful of cases where we've used lit for multiply recurrent meningioma and other things, I don't think we really help that patient.
Thank you.
Just to piggyback off that for a second, I think there's something that Dr. Luthart brought up that was kind of a quick piece, but I think is really, really important. And I think the extent of ablation and the extent of resection are thought to be pretty much the same. So if you can get a gross total resection, you can get a gross total ablation. Probably the effect is the same, but a debulking with lit and a debulking with surgery probably will have the same outcome. It's sort of my general thought. And please, anybody feel free to chime in if
It makes sense.
And again, one of our papers, we actually looked at that, like, what percentage volume, kind of seems to, get a meaningful impact. And again, it's kind of like craniotomy, that you've got to do at least better than 90% to see a clinical impact. Yeah, and the more you can get and for metastases, I actually think it has to be by imaging supramarginal to see kind of a good control of the disease.
Yeah. I agree completely. That's my experience as well.
I guess along that line, I know you said it has to be less than 3 centimeter. Is there a role of fractionating this? Like, is there a role for like breaking it up into pieces and then come back maybe another day?
It's a really good question. So it depends on the pathology, I would say. So we definitely do what I call staged laser ablation, on certain types of tumors. They tend to be the lower grade, slower growing, because basically you do an ablation, you get a certain volume, you wait a couple months for that tissue to kind of regress, and get absorbed, and then you treat. So for low grade gliomas, it's absolutely fantastic. And we've done a lot of large low grade gliomas that way. I think if you've got a faster growing pathology, like maybe a MET, so those are intermediate how they grow, but certainly not a glioblastoma. You can't wait a couple months to kind of stage it. And again, I'd say that 3 centimeters, it's not a hard cutoff. That's why I was kind of cautious about saying that, but that's where you will start to see, more mass effect. They'll be in the hospital for longer. It's not a showstopper, but it's just kind of how you counsel the patient, how you talk about it at a tumor board for what the expectations for the outcome are going to be.
That's great. There's one other question that I have some interest in as well, just relating to the multidisciplinary nature of spinal metastases. So the question was, have the number of patients eligible for spinal lit lowered due to the advances in radiotherapy, specifically spine stereotactic radiosurgery, and better targeting with some of the imaging modalities that we use in this day and age, and less need for separation surgery by lit or open surgery?
I would say that there's definitely an ebb and flow of cases that we end up doing, but I don't think that there's been a consistent downtick in the number of cases. Generally, if a patient has Bilski 1C disease or higher, at least here with our radiation oncologists, they would prefer for there to be some type of separation surgery, whether that's open or lit. And so, as I talk to our trainees, when we get consults about, these types of cases, if there's significant spinal cord compression and the patient is neurologically intact, then I, try to get them to think through what are the treatment options, open surgery versus lit, and then trying to understand, what are some of the nuances when looking at the imaging to say, lit's really not going to work here versus I think lit might be a great option. And so there's some kind of nuance to that decision making, but as a whole, I don't feel like we have decreased our like separation surgery numbers for like Bilski 1C disease.
And I guess along the line, there's a question from Dr. Mansouri about CSF acting like a heat sink in these cases. Can you comment on that? Like, do you have like hard time heating all the way to the desired temperature?
It really depends more on the the nature of the tumor itself. Whether a tumor is particularly vascular or like the chordoma case was a case that Dr. Tatsui did, but like the composition of chordoma is going to be significantly different than renal cell or melanoma, something like that. So really the CSF, generally the CSF is significantly obliterated, by the tumor when we're treating it. So I think some of those heat sink issues that you think about supratentorial lesions that may be close to the ventricles are a little bit different than what we are experiencing in the spine.
I guess I do have a question for Dr. Mansouri about, you said you were sampling the CSF even with patients who didn't have like visible CNS disease, and you were finding, or leptomeningeal disease, but you were finding cells. Were there any like markers in their blood that would like predict that if they will have cells that will metastasize to the tumor? Is there a way to predict that before the disease shows up in the brain?
You mean the positive cytology study, the CSF?
Correct. Like, is there like a blood biomarker instead of like a CSF bio? Is there a blood biomarker that'll say if the cells are gonna, or if it is eventually gonna metastasize to the brain?
Right. So I don't focus on the blood, and this study was in blood, but I think going back to that clinical pathway, I think we know EGFR positive lung cancer patients are more likely to metastasize to the brain. So perhaps those would be, or like triple negative, HER2 positive breast cancer. So perhaps those are good patients to at least start enrolling in studies to see if sampling their CSF in the absence of any obvious brain involvement can help us detect early on whether there's infiltration of the CSF and then subsequently brain. But no, to answer your question, we didn't look at the blood.
There was one other. Go ahead, Mahua.
Sorry, I have one more, like a quality of life question, since we talked about quality of life in our first section for Dr. Eric. I'm sorry, I'm going to say your last name wrong.
Uthard? Is that me?
Uthard, that's right. That's right. When you're doing the lids, early study for like insular glioma that Fred Lang did, there was like extensive, these like quality of life studies that went with it. Like, when you're doing lit for these, are you doing like parallel studies? Because some would say, well, we can still resect these, but when you look at some of the Fred Lang's older study, the cognitive issues, like the quality of life issues, did add up. Does lit do better in that sense, or are you doing those studies?
So, I mean, I can't say about gliomas expressly, but when we looked at brain tumors generally for lit, we expressly did, formal quality of life measures, and that quality of life, was all improved with laser ablation. So that, and I think we can extrapolate that to gliomas, and certainly, I mean, just as a surgeon who does both open and laser, and historically I was a big map and still am a mapping guy, but the difference in kind of quality of how, like, again, a patient with an insular glioma goes home the next day. They kind of maybe take a couple weeks to recover just from anesthesia. A open craniotomy for an insular surgery, they have a higher risk of morbidity, and it's just that's well documented. And so, and again, when we compare those, the differences in morbidity, it bore itself out from a statistical standpoint. So I think that the quality of life, for lit, again, generally for tumors, consistently shows, kind of statistically meaningful findings that the patients, do better by all the, the formal brain tumor metrics. And then anecdotally, for, just what you see for length of stay, time of discharge, and neurologic morbidities, patients do better for insula stuff and specifically. Did that get to did I answer your question?
Yeah, no, well, that's good.
Great.
Any other questions amongst our speakers? I think we've reached the end of the list, it looks like, for within the chat.
I guess there's one more, sorry, in the chat that says, is lit an option for
sorry.
leptomeningeal dissemination of brain mets?
I personally am going to go say no. LMD is widely spread disease and lit really is focal treatment. And so I personally don't see a role for it. I wonder if there may be a role in terms of an experimental role for it as an adjunct to something else. But because LMD is so widespread and lit is focal, I personally don't think so.
Were you thinking of prompting an immune response or something, Mahua?
I'm not sure. The question is from one of the.
Gotcha.
I think they were thinking maybe even if there's no imaging improvement, is there a quality of life improvement associated with that?
I mean, LMD is such an aggressive course; those patients just tank so quickly. Once you see LMD on imaging, their time is limited, and the symptoms are things like seizures, poor appetite, vomiting, altered mental status. And so oftentimes a focal treatment like lit that cannot alleviate those types of symptoms.
Yeah, I would agree with the same. All right, I don't see any additional questions. I want to take the opportunity to thank all the speakers and panelists and attendees to making our 5th annual Multidisciplinary CNS Metastases update such a huge success. Your participation and contributions have really made this event invaluable, and we really hope that you found the discussions insightful and enriching for those that were in attendance. Please help us to make our virtual conference better by completing your course evaluation, which can be done immediately after the symposium or via the link sent to your email today. We really do value and take into account that feedback in order to consider topics for discussion for next year's event. We are already in the midst of planning for our upcoming Wisconsin Primary CNS Malignancy Symposium on April 11th. That is going to be more of a general CNS presentation, but until then, we look forward to staying connected, and thank you for your ongoing support. I did want to take the opportunity to also personally thank Janelle. Janelle is our master of puppets, so to speak, behind the scenes. We would not be able to put this conference on without her tireless efforts for chasing down our speakers for their slides and their consents and disclosures. So Janelle in true form is still behind the scenes, but just an incredible part of our team. And like I said, we wouldn't be able to do what we do without all the help that she gives us. So Janelle, tip of the cap to you.
Yes, and I would also like to thank Chad, who is like the IT genius who makes this all happen. So with Janelle and Chad, they are the cornerstone of this.
Wonderful. Well, we will close out our event. Thank you, everyone, again, so much. This has been just an incredible morning. I've personally learned so much, and looking forward to the next time that we all convene. Thanks.
Thank you.